Hello, good afternoon everybody. I'd like to welcome you to the third Health and Adult Social Care Review and Scrutiny Committee of the municipal year. Before we start these proceedings, may I bring to your attention to some housekeeping matters. There is no expected fire alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the council house. The meeting will be broadcast live to the internet and will be capable of subsequent repeat viewing. By entering the Warspite room, committee members are consenting to being filmed throughout the meeting and to the use of those recording for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you're not using it. Your mobile devices are turned to silent. So, item 1 on the agenda, apologies.
Thank you, Chair. I received apologies from Councillor Krizanak. Councillor Rainsford is substituting today, and apologies from Councillor Watkin, who's running late. Thank you.
Is there any other apologies for Councillor Nicholson or Councillor Finn? Oh, we've got Councillor Finn. Councillor Nicholson? No? Okay. Okay. Item 2, declarations of interest. Any declarations of interest?
I work for Plymouth University Hospitals NHS Trust at Derriford.
Thanks, Will. Anybody else? Nope. Okay. Item 3, minutes of the last meeting. Can we approve the meeting minutes of the minutes? Approve. Anybody? Everybody? Yeah, we've got Councillor Noble, Councillor Ricketts. Yeah. Okay.
Any objections?
Any objections? Any abstentions? Everybody happy? Brilliant. Item 4, Chair's urgent business. There is none. You ain't got none. Okie dokie, we're going to go to item 5, quarterly performance and financial update for health and social care. We've got Rob Soden and Helen Slater. Rob's going first. I'm just going to remind you that these are reports just to note. Thank you.
Thank you, Chair. Good afternoon, everyone. There's a lot of information contained in the report, which starts on page 15 of your packs. As I always say, this serves as only a fraction of the data and information that we have access to via our system dashboards and other methods, and that we use operationally. So if you do have any questions about any data outside of this meeting, please don't hesitate to contact me. This report continues to evolve as we are always working to strengthen the governance around performance management. This is hugely important as we are again in a period where local authorities will be subject to Care Quality Commission assessments. For that reason, as we move forward, the appearance and content of this report is likely to change. As always, though, as I've already said, if you do have any questions around that, then don't hesitate to ask. I won't, Chair, go through the report line by line, but I'll just give a headline from each of the sections. Page 18 gives an overview of demand via the Live Well South West referral service. And whilst demand remains relatively steady, our colleagues at Live Well continue to do a lot of work to reduce the waiting lists. This is evidenced with both waiting lists for adult social care support and adult social care occupational therapy on a downward trend. Page 19 tracks our safeguarding concerns. These are alleged incidents of abuse on adults. Not all of those adults will be in receipt of an adult social care package. We do report a lot more information than this on safeguarding to the Plymouth Safeguarding Adults Board, who hold the remit to scrutinise us on that. This report gives us a view on the outcome to adult social care safeguarding investigations. And in quarter 2, 94.9%, that's of 59 people, had their making safeguarding personnel outcomes fully or partially achieved, which is a positive outcome for those individuals involved. Page 20, we continue to face the challenge in relation to long-term placements in residential and nursing care homes. In 2022-23, for example, the number of admissions of older people into nursing care increased by 57%. Those higher admission numbers continued in April and May of this year, but since June, we have started to see admissions start to slow, which is a positive. The year-to-date number of admissions is still higher than last year. That's between April and October. We've had 213 compared to 210 last year. Those figures, though, are closing. You will see on the page as well that the numbers of people in nursing care homes, whilst plateauing, remain high and contributing to a number of challenges in that area. Page 21 illustrates our much improved position in relation to the number of people waiting for a domiciliary care package. To give you an idea on how much that has improved, and that improvement has been maintained, I should say, the waiting lists, the number on the waiting list on the 11th of December, which was Monday, was 11, which is 91% lower than January of this year, when the number was at 137. So that improvement has been made and is being maintained. Not only is the waiting list down, but the waiting times on that list are also low. As of yesterday afternoon, at which point there were 15 on the list, 87% of those people, which is 13 of the 15, had been waiting for less than a week, with an average waiting time of 3 days. Page 22 tracks the number of people in receipt of a direct payment. It's on an increasing trend over the long term, which is what we want, as more people in receipt of a direct payment means that more people are spending money on the care that they want. The percentage of eligible users who receive a direct payment rose to 26%. And that's just 0.2 percentage points below the national average from last year. Historically, we've been further behind the national average than that, so we're closing up and we'll hopefully, as we go forward, start to be above that. Page 23 tracks numbers in our Independence at Home reablement service and the associated outcomes to that. On average, last year, 66% of people left a period of reablement with no ongoing needs. That, of course, is the best outcome for those individuals. In October of this year, that percentage has risen to 77.3%. Page 24 gives us an overview of the adult social care complaint numbers. Year to date, the number of complaints is down on the same period last year. Between April and October, we had 60 complaints, and this year we've had 52. And on page 25, that gives us an overview of how the commissioning department performs against the Plymouth City Council key corporate indicators. Performance against our FOI compliance remains good, and although still a challenge, the levels of sickness are also starting to show improvement. Always conscious there's a lot of information there, but happy to try and field any questions, and Gary's on screen as well for me to refer to if I can answer them. Thank you, Chair.
Just a quick one, Rob. We're talking about the domiciliary care, and you were saying that it's gone down to 11 people waiting, which is brilliant. But do we know, I mean, I'm assuming before people can have this domiciliary care package, they need to have an assessment. So, but that doesn't, it's not said anywhere here how many people we've got waiting to have an assessment. So can you just give me any sort of figures on that?
So it is a challenge for us Chair, around assessment and review activity. That does get reported in our operational performance reports. It's not in here. I know I've had conversations with Gary about lifting that up into this report, and that's certainly one of the indicators that we want to bring to you as we strengthen the information that we give you. Off the top of my head, I can't give you any average waiting time numbers, but the number of people awaiting an assessment on the system are much higher than we would want them to be. I can't remember off the top of the head what that is, but I'll happily provide that information to you after the meeting if that's okay.
Yeah, no, that's really, really good if you could, because obviously that looks really good, but when we dig down deeper, actually, if we've got like hundreds of people waiting to be assessed, it's not that good, really, is it? So I would love to see that on that report, on this report as well. So thank you.
Also on the domiciliary care, do we have a breakdown of how much is short term based on potentially somebody that's, say, come out of hospital or has had a recent fall, that type of thing, compared to those that actually is a long term, so that, you know, are we planning for that or have some overview of that?
So unfortunately, it's going to be a similar answer that I can get that breakdown for you. Can we get it? Absolutely. It's available on the dashboards. We can break it down by intermediate care. And as you say, those who are going into a long-term support, absolutely, we can break that down any which way you'd like, really. So I'll contact you and ask how we can do that to help.
Alison?
Thank you. I'm just actually seeking some clarification. Page 17, you have a figure which says 12,030 requests for support for new clients. And then below that, you've got 4,516 people accessing long-term social care. Are those new people or existing people? Do all those figures underneath that top line mean these are newer?
So the 12,000 figure is the number of people who contacted us in the belief that they may need adult social care support. So that's the figure that's come out of our last statutory return. So each year we have to submit numbers. So those are numbers of people who are approaching us. Not all of those will then go on to receive that support. Sorry. Yeah.
That was my question. Is that 4,000 figure the number of people from that 12,000 who have gone on to receive, i.e. they are new people, not existing people in system?
They will be both. It's not a sub figure from the 12,000 because that's all people, and they may include people who have been receiving care for a number of years. All right. Sorry that that's not clear in there, but it's not of that 12,000.
It makes sense.
Okay.
Well,
I've heard about the Care Quality Commission, and they're going to assess local authorities. So the performance information we have here are they what we're looking at and monitoring, if you like? Are they the same criteria that will be monitored by the CQC?
So CQC will be looking at all published information around Plymouth, so we'll be looking at all our statutory returns that we've submitted, both around performance, activity and finance. We've got an agenda item on CQC later on where we'll go into a bit more detail around it. But you're absolutely right, they will be interested in these metrics and more. And it is that wider basket of metrics that we're working on to almost get that central pillar of performance information, which is why I said at the beginning that this report will evolve. So a lot of that almost like whole picture stuff will start coming into this committee.
supplementary, Will, or you're fine? Okay. Angela?
Thank you, Chair. Page 20, it may not be significant because I realise the numbers are quite small, but can you give any more detail about the reasons for these trends, both the trend behind the fall in those going into care homes and residential, and then the slight increase in nursing? I mean, does it in fact mean that it's people moving out of care into the more complex needs of nursing? Yes, okay, thank you.
The numbers in residential care have settled down and are, in fact, as you point out, started to come down, and that's good, because obviously the more people who are receiving their care in the community, that's better for them. So to see that number coming down is a good thing, as we are the admissions. What we aren't seeing yet, although a lot of work is being done, is the numbers in nursing care go up. They've plateaued, but they are a lot higher than when they were, and naturally that is higher level support needs, so costs more money, so it has implications in that area. In terms of the actual reasons why, I mean, I could give an umbrella comment that it's more complex needs, which is exactly what you probably are thinking. Gary's got his hand up. I'm happy to hand over to Gary, who may be able to add a little bit more information on that.
Thanks, Rob. And just to add a little to that, and I think Rob's touched on a few points which are really relevant, but if we listen to our health colleagues who've talked a lot about a higher acuity of need in terms of people presenting at their door, what that then unfortunately can mean is that will pass through the hospital out into adult social care. So we have seen an increase in the numbers of people with more complex care and support that's required, including those requiring nursing. So that's why we've seen that go up. The only other comment I would add about residential in terms of the numbers, where they seem to have plateaued and just dropped a little now, that's pleasing from our point of view, as we've seen the domiciliary care workforce return, and we've been able to grow that workforce and strengthen it, which means we're able to do more now to keep people at home as well. So I suspect what you'll find is there's an element of that now positively keeping people at home and therefore reducing the numbers as well. Bit one of the factors that will reduce some of the numbers in residential, which is really good news.
Alison?
Thank you, Chair. Some of these figures are actually looking very positive in terms of waiting list falls and one or two others. Are there particular reasons why that is happening? Are you operating a different triage system? Have more staff been employed? Or is the system, are people just simply not coming into the system as they were 3 months, 6 months ago?
I'm going to keep looking at the screen in the hope that Gary puts his hand up at some point, but I will, and he has done. But I will. What I will just say is Gary touched on workforce development there, and that certainly will have had a big impact on the domiciliary care one. I'll hand over to Gary, who's add to that.
Thanks, Rob. So, and yeah, thanks for your question. So some of those figures are really quite positive, which is nice. I think I would just like to make reference to what Pauline said. Not everything is positive in the service, and I think there's some other information that we can share, but these are a lot more positive, and a lot of that is down to the work that's gone on in terms of workforce and seeing a workforce recovery. Rob talked about 137 people waiting for dom care, which is why that's a report that comes to scrutiny, because that number was high. It was even higher than that at some point, which was as a result of the workforce challenges through post-COVID. And I think we've seen that recover. We hope that recovery holds, maintains, and continues to grow, but we don't yet know that that's the case. I think the other thing that we've, as a system, been able to start to do is to recover, if you like, a little bit from everything that was happening through the pandemic. And some of that work can take quite a while, but I think we've certainly seen some of the shoots of that as well, which is really helpful for us.
Paul?
Thank you, Chair. Page 23, the reablement figures are fantastic, but Do you monitor those people to see that they don't present themselves again in a few months' time? Is that proper permanent reablement?
So there's a national indicator which requires us to check what their status is 91 days post hospital discharge. So whilst it's not post reablement, it is post hospital discharge, and a lot of those people will go through reablement. So it's essentially a metric that assesses our reablement or any other rehabilitation type service. So we do track that. That is at around about 77% as well. It's not as high as the national benchmark, so it is another indicator that we want to improve on. But yes, there is one that we are able to see how we perform against that a little bit further down the line. There's also some other metrics that aren't in here around readmissions and things like that. So there are more metrics that we can do or we look at across health and social care to determine just how successful the discharge process is, but then the care that they're receiving post that discharge, and whether it's improving their prospects longer term.
Absolutely.
Yeah, just go back on that. If there's a national benchmark that we're in, can we have that information on there so we can see how far off we are?
Yeah, we can. There's been an acknowledgement within the department that the information that's in here has not. It's been a bit pick and choosy, which I don't like to say that, but I think that's just what it's been, and we want to move away from that. So there's not indicators being left out because they're bad or anything like that. It's just if we brought you every indicator, honestly, the list is huge. So we tend to bring stuff that feels relevant. This metric is specifically assesses our own reablement. That's why that was chosen over the other one. But absolutely, the 91 days one can be added in.
Any other members? Any questions? No. Thanks for that, Rob. I'm going to move on to Helen now. Helen's going to say her bit. Thank you.
Thank you. I'll just share. So the finance report is the position at the end of Q2, which is month 6. Adult social care is still reporting a pressure of 1.298 million, and the cost pressures driving that and volume pressures are within dom care and long stay nursing still. We have had additional income in from grant funding and client income to offset some of these pressures. But behind this, we're also acknowledging there is a potential risk from our forecasting that the pressure could increase by the end of the year. At month 6, when we quantified that risk, it was 2.4 million. However, we are confident there is a lot of work going on behind the scenes to mitigate that pressure. So hence, we're not reporting it as part of our forecast. And actually, at month 8, we're seeing that risk has come down significantly. So there's not really any concern about that full amount any longer. And examples of the mitigations that have been ongoing is a lot of detailed deep dive work into all the different care package types with the service, finance and project officers to drive down savings, maximising income streams from grants and funding from health, ensuring we're recovering all the funding we can from our health partners. And also bringing in the scheme of delegation, which we have seen the tightened governance arrangements from the scheme of delegation has brought down our forecasts almost immediately from when that was brought in. We are confident that we are going to fully achieve our delivery plan savings target. So that's the 3.7 million that was in this year's budget. At month 6, 44% of that had been achieved, and the rest was all green and amber, so there's no risks. And we're confident now that any savings we see going forward are going to bring down the final amounts of the risk figure mentioned previously. And in the report, there's a little table of how our delivery plans were broken down this year, and how everything is on track to be delivered, and we're confident about that. So I don't know if anyone's got any questions.
Any members got any questions? We've got to make a saving of 3.7 million. How are we going to do that? And my fear is, Helen, as the colder months go on, we might see an increase in people that's going to need care or whatever. How are we going to manage that if we've got to make a saving of 3.7 million?
Yeah, so I'll come back down to here. So mostly we have identified how those savings are going to be made. The bulk of it was through package reviews, but we have had we were able to offset some of these savings by direct payment clawbacks and staffing savings within the service. So we are confident that that will be covered. But however, they are by nature one-off savings, so it kind of we comfortably be achieved short term, but then long term for MTFP and budgets, that's where the difficulty comes. But you are right, we could our pressures could go up across the winter, and that's what we're trying to do in our forecasting to anticipate that. So those numbers are kind of already in our forecasting. I don't know if Gary, you want to come in and add to that.
Yeah, because it's a really right question to ask us. I think you've answered a bit about the money. That 3.7 is virtually done now, so we think that's really low risk in terms of that money has come out. What we also do in terms of our forecasting is we know winter's busier, so what we've already done in our forecasts is we've included that a level of expected busyness. What we don't know is if we were right, and that's the bit that we then track through the winter, but we expect it to be busier. We have forecast it to be busier, so therefore we can be more confident that we've got that right. What we do in our monitoring is check, was it as busy as we said? And it will never be what we said. It'll either be more busy and more activity or a bit less, and that's what our monitoring will do for us, and that will help us hopefully get to year end.
Can I just pick up, Helen, when you said that you've been saving on care packages? Can you just elaborate more on what you mean by saving on care packages?
So it's care package reviews. So we have a budget containment group, and part of that group we've identified sort of high cost packages to be reviewed, and to ensure that it's not necessarily about reducing costs unnecessarily. It's where we're kind of rationalising the package, and sometimes that does produce package savings. So it's not really taking care away from anyone, it's just checking that everyone's at the right level of care, and sometimes that produces a saving. Gary will elaborate.
Just to add as well, that one of the things that's really good practice to do, particularly when people have come through the hospitals, is to do a follow-up review, because people's needs don't always, when you first assess, particularly if you've come through a hospital route, they don't always stay the same. So that review is actually something which can see things move both ways. But we know very often when you come out some of those routes that actually you might need a little bit more support initially, and then you don't need it later. So that reviewing is really good practice for us, for people, because actually people want to be as independent as they can, and we need to help support them in achieving that, and leaving care in doesn't always help. So, but recognizing that can cut both ways for us, because it will do.
Anybody else got any questions? No? Okay. Thank you so much, Helen. Thank you so much, Rob.
Thank you.
Just thank you for all what you've done over the year, and wish you a nice Christmas.
Thank you. Merry Christmas.
Bye. I don't think there was any recommendations from that. Yeah, just a note. The only thing that I would like is the assessment percentages put on there. But it's not a recommendation. I just would like that on the report.
Yeah, I've recorded in the actions for that one, Chair, that the performance report's going to be reviewed to bring back assessment percentages and additional details as members requested.
Yeah. Thank you so much. Item 6, no right to reside. It's an update. It's from Gary. Just like the committee to note that this is just to note. Thank you, Gary.
Thank you, Councillor Murphy. The last time I was here, I think I reported for you percentage no criteria to reside figure of 11.4% versus the target for no criteria to reside for UHP, which involves Devon, Cornwall and Plymouth, of 7%. So there was some work to do. The positive position we're in today, and the update I can give you is that figure is now 8%, which is really fantastic news. That puts us a lot closer to the system target, which was 7, and puts us only a small number of delays away from achieving that. So I'd like to firstly, I think we should, and I know people will want to acknowledge and say thank you to all the hard work that everyone in the system puts in what is a time of really extreme pressure for our hospital system. That's really good progress. Importantly, I guess I would just like to add that the plans that the system has made for winter, of which we're just a part, has a number of initiatives on it, and some of those will continue to bring in more capacity, some of that being home care capacity, but also some other forms of capacity as we go through the winter. So I guess what that does is it gives us some hope that if things work out as predicted, we can at least maintain or slightly improve that position. What we don't yet know is, of course, is what the demands will be through the health system. But in terms of the modelling, I think we would say we feel like we're in a fairly good position, recognising there is always more to do, because you'll see the news and you'll see the pressures, which are relentless for our health colleagues, and we'll be pushing as hard as we can to get those numbers as more positive.
Any questions from members? Everybody's feeling. Oh, Bill?
At our last meeting, they discussed the target of getting down to 7%. So they said they'd done some work. There was some acronyms. I can't remember the projects to work down to these targets. So has this target been well, this target getting it down to 8%? I think it was much higher. It was like at 14, I think, but at the last meeting, if I recall. So getting it down to these numbers, is that as a result of some of the work and the ideas that they perhaps came from those workshops, if they did that, or are there some other one-off things that have happened to get down to this target number?
Yeah, thanks for your question. You're right, the number was even higher. I think I said the last time we came it was at 11.4%. It's been higher than that, and the reason the number has got down to 8% is because of the work the system's put into executing the plan, and all the schemes and initiatives that they put in place as part of the winter planning, which started many months ago. So there are a number of schemes. For example, there's one that we call our peripatetic team, which is building on and having additional capacity to our independence at home service. And what that does is it means more and more people can leave hospital and go directly home, which is really something we've been keen to do and promote. But that's just one of those initiatives. So it's just to answer the question, that is absolutely execution of the plan that people have put in place.
Okay, well. Anybody else? No. Thank you so much, Gary. I do appreciate the report, and we'll see you later on in this meeting anyway, won't we? So, thank you.
We will. Thank you.
Just a quick one. We are actually ahead of time. So Joe and whoever we need is not here at the moment. So, with the agreement of the rest of the committee members, if we go to our tracking decisions, it'll save us doing it at the end. So is that all right with everybody? We go to item 11, just go to tracking decisions. Yeah, thank you very much. Elliot.
Over to me. Thank you, Chair. So as members will note, I've cut down the logs, so all the ones that we signed off as complete last time that were actioned and reported to yourselves I've taken off. So we're now just down to 12. 4 of those marked complete and 8 part complete. I'll run them through roughly in order since we've got time today. So the committee requested that future performance reports contain statistical waiting times. Those were included in Rob's report today, and obviously we've added further to that, requesting further data and statistics and a change of that. So I'll pick that up with Rob outside. The next one was regarding financial implications of compensation awards in regard to the LGO complaints we had. Members will have been copied into an email I sent a few days ago with an example letter. If members would like to bring up any suggestions on that, we can bring that back for review. And where the Cabinet Member for Health and Adult Social Care is also reviewing our approach to those letters. Moving on to the third one, we have reviewing the methodology for domiciliary care procurement at a future date. So that's been added to the work programme. You'll see it on the list, and we'll add that as and when necessary. We'll come on to the work programme probably after this item, Chair. Number 4, the committee agreed to request further information regarding sex workers incorporation in the seasonal immunisation programme. You'll see a response below from Alex Deegan. So if members are happy with that, I will tick that one off today. Number 5, the committee recommended that councillors promote and share the Choose Well campaign and an NHS Devon communication strategy within their wards and communities. This was a key part of the winter preparation and preparedness. Trying to do our bit to get the message out. Chair and I have since received an email, so this one can almost be marked complete. We will circulate that, and there's further information on the Councillors Hub that's been added. The comms team will also be doing some work on that.
Well,
Can we be, if at the last meeting there was, I think we were asked to share some of the Choose Well campaigns about persuading people to find other ways of things other than turning up at the hospitals. Or so I'm not sure I've received any emails since the last meeting about the Choose Well, social media to share and what have you. Cause
yeah, through you, Chair. I'm holding it in my hand. We received it today or yesterday, so I will get that out to you by the end of the meeting. To me. So recommendation number 6 comes back to defibrillators. There is an update for you there. The only reason I've marked it part complete is because not all of them are in situ, so I want to keep it on the log until they're all fully there. So if members have got any questions with that, they can be directed to myself around Thorpe.
Can I just ask, is it the right way round? Is the one at the ride available only during the day and the recycling one 24/7? It's probably the other way round, isn't it? The ride would be publicly accessible. The recycling centre presumably would be shut at night. I don't know.
Yeah, I'll through you, Chair. I'll chase that one up and get a confirmation on that. That's just word for word what I've received. Okay, moving on to number 7, the Youth Parliament. This is number 7 and number 8. Those both, you'll be pleased to know, now being actioned or started to be actioned. We will be following them up and keeping tabs on them, but I'm aware that it's a wider piece of work. There isn't really a quick solution there. The second part of it, number 8, there is a quicker solution, and I'll check to see whether that's gone out in their head teachers' bulletins and things like that. Moving on to number 9, Mental Health Select Committee, social prescribing. That's now complete. We've received a response. Again, if members want to check that and look through that one. Number 10, there is a wider work piece to be done here. This falls into part of the Armed Forces Covenant. I'm having a lot of conversations with Live Well and other organisations. I think there's a need to get them into an Armed Forces Covenant meeting and to share expertise. So I'll pick that up with yourself, Chair. And then last but not second to last, the NHS Devon 15 working days as part of the GP surgeries affected by the Cavell Centre scrappage. That obviously is going to come back today as part of our GP item. So that's why that's on there to be completed today. Any questions? I'll try and take them, Chair.
Natalie.
Yeah, sorry. Thank you, Chair. Just on the mental health that committee regarding Armed Forces Covenant, you mentioned Live Well. So it's a plan to get all of the organisations that are working with veterans on board with this, so that it's not just Live Well, but some of the voluntary sector. that are
Yeah,
involved.
through you, Chair. It's a wider piece of work than just Live Well. I've received really positive replies from NHS Devon, from Live Well, from the Provider Collaborative. The list sort of goes on. It's there on the right. If there's any more you wish to add to that, and you think there's suitable organisations, then by all means we'll get them involved.
Alison?
Yeah, can I ask, the wrote to the Veterans Minister, point F in this section, asking him to work cooperatively to boost communication and signposting for veterans. Have we had a reply from the Ministry of Defence?
Can you just point me to which?
Page 92, rec number 10, little f, at the very bottom.
Through you, Chair. So that action hasn't been completed. That's why the whole section's marked part complete, because some of they come in steps. So we have to organise the meeting and agree the participants before we can write to detail the exact plans of when it's taking place. If you're talking in relation to point F.
Yeah, no, I'm just curious because this is in March, and a letter to the MOD seems something reasonably straightforward that could be done at the beginning of the process, not have to wait for all those various other steps to happen.
No, sorry, I think that's confused up there. I thought you were on about point F, writing to Johnny Mercer. The MOD letter has been done, I believe, and I'll circulate a copy to you as soon as I can.
Sorry to seek further clarification. So you wrote to Mr Mercer as the local MP, not as the Veterans Minister at the Ministry of Defence?
Are you on about point F, Alison?
Point
Yes,
F on page
page
92, where it says Chair writes to Johnny Mercer MP, advising. And my question was, have we had a reply? I assume it was written to Mr Mercer as the Veterans Minister. And have we had a reply to that point? Because it's a fairly bland point.
Yeah, so that action hasn't been done because we haven't arranged the meeting yet. That will be done, and Chair will have eyes on that.
Anybody else? Okay, thanks. Thank you, Leah. Right, we're just going to go to item 12, which is the work programme. Elliot.
Thank you, Chair. So, as you will see, provisionally scheduled for next session, our last one of the municipal year, we have the residential care homes commissioning plan. Due to the fact that we considered the commissioning of domiciliary care and other items, and it was brought up by members, how do we actually commission care homes? So that one is on there under Emma Crowther for scrutiny of that. The other big session we have, which initial talks were looking like we almost run it like a select committee, but within the meeting we bring in expertise or experience from all sides and angles. It was end of life care, a big issue which has come up over the year with quality of care, standards of care, and what is that end of life transition. We've looked at communities, we've looked at hospitals. Now, how does that link together at end of life? Obviously, there's more items at the bottom, and those are only provisional. So over to you to discuss, Chair.
Any members got anything that they would like to be put on the work programme for next, I'm assuming next time? No, they're very silent today. Okay. Sorry, who? Will?
I think the wellbeing hub, update in future sites, because I think it's quite an exciting project. There's lots going on, isn't there? I know Natalie and Councillor Harrison is involved with the community builders, and there's lots going on across the city, and lots of those low-level health and well-being things are happening there, which is what we're trying to do, get combat loneliness and whatever. So it's quite important, and it's in our communities as well. So.
Can I declare an interest as community builders, as mentioned?
Yeah, you can if it goes. Our members quite happy for myself, Natalie and Elliot and relevant council officers to sort out the work programme for next time. Yeah, okay, there's your answer, Elliot. Okay, thank you.
Drug and alcohol things.
Okay, we're going to go on to item 7 now, GP practice, and we've got Joe. Oh, have we got Alex? And have we got Matt?
So it's just, yes, I don't know about Matt, but Alex will join us, but he can only join us for part of it. So I'm gonna update anyway, and Alex
Okay.
is really here to help me take some questions. So that's fine to carry on.
Okay, lovely, thanks, Joe.
Oh, sorry.
I'm ready, Joe, when you're ready, my lovely.
Thank you, Chair. I'm just waiting for Elliot to pop the presentation up. So you've had it beforehand, but I was just going to use it to run through. Very happy to say that Alex has joined me now. So just I'll let Alex introduce himself for you.
Thanks, Joe. I'm Alex Deegan. I'm a GP in Devon and the primary care medical director for the ICB. I'm happy to be along to support Joe with any questions.
Lovely, thank you, Alex. And hopefully most of you recognise me by now, but for those who don't, Joe Tell, Director of Commissioning Primary and Community Services at NHS Devon, and glad to be back here. Thank you for inviting us back to give an update. First of all, on general practice, some specific areas you wanted to focus on, which I focused on in the presentation. I will try and go through the presentation quite quickly because you've had it beforehand, so I'm going to assume people have looked at it, and I want to obviously open it up for discussion and questions as soon as possible. And then later on, obviously in the agenda, we'll come to the community pharmacy piece. So Elliot, are you my next slide, please, person? Thank you. Lovely, thank you. So first of all, an update you asked for on the West End development. So the work that we'd obviously been doing collaboratively for quite a while, which involved 3 of our GP practices, the 3 practices on there, so Adelaide Surgery, Armada Surgery and North Road West Surgery, which involved them moving into a health and wellbeing hub in the bottom of the city centre there. As we know, unfortunately, those plans haven't come through to fruition in the same way as we had originally planned, but you wanted to know specifically what's happened with those practices since that announcement. We've been working very closely with those practices, so if I can just ask you to go to the next slide, if that's okay, just for a little bit of an update. So we've been working with those 3 practices, but we have been working on a wider piece of estates work across Devon, which is called the NHS PCN, so Primary Care Network Estates Toolkit. So we've basically worked with every single primary care network to assess their current estate. We've done that with a view to, and it's a national programme with a view to identifying where there are opportunities to invest either in existing estate to make that fit for the future, or where we've identified that there are some serious concerns about sustainability of estate in the future, and that actually that needs a significant remodelling for the future. I'm pleased to say as part of that process, these three practices have come out as a top priority in terms of any future funding we might get as part of that process. We're continuing though to meet with the practices in the interim, so that's chaired by our primary care estates manager who works in the primary care team, but it's also supported by a project manager who directly reports to the estates director, just to explore if there is further funding for a solution for those practices in the medium to long term, to make sure that we're ready for that and ready to be able to put a business case together for that. I am pleased though, several things. First of all, the links with Plymouth City Council are still really good in terms of this project, so continue to work together. Plymouth City Council, as we know, have always been very supportive of working with these practices. And also those practices as well are able to continue in their existing premises. So there were some issues that we're working through with those practices and their landlords. Really pleased to be able to say that they can stay in their existing premises. There's no risk to that at the moment. And indeed, we have identified some opportunities as well to provide some additional space, which we're currently working with one or two of the practices on. However, I do need to stress that we know those premises aren't all fit for the long term. So that's why undertaking that piece of work across the whole primary care estate in Devon was a really important one to do. What's worth saying is that was a national piece of work that we had to do, was to review all the PCN estates. There was no explicit funding attached to that. But what we have done is we've done the piece of work. We know where we've got the opportunities and where the biggest priorities are. The next bit is getting ready then. So if there is some funding, we've got something that's ready to go. We did have an update just a couple of weeks ago from our Director of Estates in the NHS that said he'd had an update from the national team which outlines primary care as a priority for the next comprehensive spending review, which of course is in 2024. So we don't know what that will look like. There are no guarantees around that, but they have said that primary care is a priority, and they've said explicitly there'll be a focus on community neighbourhood hubs. So again, no more detail about that, but that does sound at least akin to what we were trying to do, although I dare say it probably won't be on quite as big a scale as we were talking about before. So if you can move me to the next section, if that's okay, Elliot. I'm going on for the moment to talk about Mayflower. Very happy, I'll take questions at the end if that's okay with you, Chair. So again, you asked explicitly about an update on the Mayflower procurement. And I'm sorry, because during these times, it always feels like it goes really quiet, doesn't it? And that's because we've been in a procurement process. And during that procurement process, obviously lots of issues in terms of confidentiality and provider business that we can't kind of put into the sort of open forum. But very pleased, as you know, we have announced that we've got a provider for the contract. Really pleased. At this point, I would just want to reiterate again my huge thanks to Live Well South West, and I know Jeff is sat behind me there, and that's really important because they've been a really important partner with us to really make sure we secured general practice for those patients in this interim period, and have done a fantastic job in a very short period of time to turn around a CQC rating. So I do just want to reiterate those thanks again. But I am pleased to be able to say we've got a new provider. The provider is Fuller & Forbes. It's a 10-year contract, so it's a long contract, which is really good because that gives sustainability to the provider and also confidence for all of us that this is a long-term solution. They already have existing contracts in Devon, so we already have really good experience of working with them, and I'm really pleased with how that's going as well in other parts of Devon, so that's really positive. We have, as you'd expect, through the procurement process, a mobilisation plan, and that's to make sure we get the smooth transition from the incumbent to the new provider. So there are fortnightly meetings in place between Fuller & Forbes and the incumbent. We also hold monthly oversight meetings as well, which is just to make sure we're assured that things are progressing well, the transition is moving on well, and that any issues are identified. And then also provider sessions as well, so the providers getting together to really understand the nitty-gritty and the detail of some of this. We have a communications plan. So we've got quite an extensive plan behind that. Letters have already been sent out and briefings have been sent out to patients, practices, LMC, MPs and councillors and Health Watch as well. Staff employment will transfer to the new provider, so I think that's really important in terms of securing that for the staff, and the staff have been notified and assured about that and next steps. And the ICB is supporting the other Plymouth practices as well, if needed, with any temporary list closures. So we're not actively advocating that, but we are very conscious about these uncertain times. It can make people feel uncertain about what's going to happen, but what we don't want to do is destabilise the rest of the practices in the near vicinity either. And we don't have any identified issues of concern that are significant at this point in terms of the mobilisation, so we're all on track in terms of timescales as well. And in fact, I met with both Fuller and Forbes earlier on today just to confirm that as well in preparation. Thank you, Elliot. Okay, so in terms of Plymouth is that okay? So I've got another 2 bits that I think you wanted me to cover, and then I'll pause, and I'm very happy to take any questions. So the first one was you wanted an update in terms of performance, in terms of our GP practices. So this is year-to-date performance. First thing I should say is, so this is national data. So this is the only real performance data we have for general practice, comes through the national system. I should say that it is heavily caveated nationally, so it is experiential data, which means they are really testing it. So I wouldn't want people to take any firm and fast views for this, but it does give us something to work with, and it certainly gives us something to speak to the practices about as well. So over on the far left there, you've got the number of appointments per 1,000 and the total number of appointments. That's actually the Devon overall figure. I think the bits that are really interesting to look at are the graphs. So I'm a little bit far away, but I can remember what they say. So appointments in within 1 day, which is a good measure of same-day access for people. As you can see, there is a national target. So it says a Devon target of 35%. That's actually a national target. And as you can see, the Plymouth locality, as with our other localities, are above that. And in fact, the Plymouth locality is above the national average as well. It is important to say there will be variation at practice level, and that's absolutely true, and we're aware of that, and we continue to work with practices in that regard, and I'll come on to what we're doing in a moment. In terms of appointments in within 2 weeks, which is your kind of normal routine, again, Plymouth actually comes out top in terms of the overall localities across Devon. But of course, again, there is variation, but really good to see that in terms of meeting and exceeding the national target, and then not quite being at where we are in terms of the overall Devon target. But as you can see, out in front in terms of localities. We've got a breakdown there by practice of the number of appointments per 100,000. So that bottom line that goes across, the turquoisey line, that is the number of appointments per 1,000 population nationally. So that's the national average. As you can see, the Devon line, the orange line, is way above that. And we're actually second in the country in terms of the number of appointments that are offered by our practice, or the number of patient contacts, I should say. As you can see, there is variation. So those bars are just the Plymouth practices we've put on there, but actually they do very well in terms of, on average, above the national expectation. What I would say about those that look like outliers at either end, and you're always going to get someone who's at the top and someone who's at the bottom, and there's not necessarily huge variation there. But as I said, this is very much experiential data, and we're still working with practices to understand what they're counting as contacts, what they're not counting as contacts. So there's a lot of work to do in that regard. And then I thought the bottom right-hand one was really interesting. So it looks just really confusing. And when I first looked at it, I thought, oh, crikey, how am I going to explain that to anyone? But what we've done is we've grouped the patients within each of the PCNs, and each primary care network has got a colour. And I'm not going to go into loads of detail about this. The important thing to note on that, so the 2 primary care networks that are closest to ED, and this is about ED attendances from those practices, are the ones, so those 2, which are Sound and Drake, so it's the light blue one and the red one. What that denotes is the practices and PCNs that are nearest to ED still have the highest level of ED attendances. So there is still, as we've always known, a huge correlation between your close proximity to ED and the number of attendances as well. So I'm just going to move on to my last section because it's directly related to what you've just seen, because this is the kind of so what are we doing about that in terms of performance? Because although, you know, it looks like we're doing really well in terms of the national averages and targets, actually what we know is there is variation, and we still know that people have problems either on the phone, accessing, getting an appointment when they need an appointment, and there are all sorts of areas which we are trying to focus on with general practice. So the Primary Care Access Recovery Plan is a national plan, so it sits alongside nationally the Urgent Care National Plan and the Elective Recovery Plan as well. And it's there for two main purposes. Those main purposes are, one, to make it easier for the patients to contact their practice. So how do you just get through on the phone? How do you speak to someone? And I've heard that loud and clear time and time again from this committee and from other committees as well as being important. And then the second one, for that patient request to be managed on that day so they know what's happening to them. So they won't necessarily get an appointment on that day. If they need an appointment, an urgent appointment, they will get one on that day. But if they don't, they will be very clear about what the next step is. So it will either be an urgent appointment on that day, a non-urgent appointment, which should be within 2 weeks as much as possible, or signposting to another service if that's appropriate, or potentially advice there and then on the phone. The access recovery plan is split into 4 areas. So one's very much about empowering patients. So what can patients do for themselves? Either by using the NHS app, so things like repeat prescriptions, booking appointments on the app, increasing their use of self-directed care. So actually what can patients do and find out and engage with for themselves? Increasing the number of self-referral options as well, so that has to be guided by clinical advice, but very much so things like access to a physio or access to psychological therapies, for example, so things that you could potentially self-refer into. The second section is about modernising general practice. So we've had a huge push locally and nationally in the recent month or so around cloud-based telephony. Pleased to say we're doing really, really well in that regard, and I'll come on to that in a moment. Simpler online consultations as well, so making this as easy as possible for patients. And we did a procurement earlier on this year, which has hopefully helped with some of that. But again, there's a renewed focus on making sure that's as easy as possible for patients. And then faster navigation, assessment and response as well. So very much about how do you triage patients right at the beginning and navigate them into the right places and get them assessed as quickly as possible. Third area is about building capacity. So this is about workforce in the main. So larger multidisciplinary teams. So we know for the best will in the world, we can't necessarily get an abundance of GPs, but also actually GPs aren't always the most appropriate professional. And we've had that conversation sort of time and time again, really, about the value of paramedics and pharmacists and physios and other professionals. And again, I'll come on to the minute how we're doing with that. So we're actually doing really well in terms of those additional roles. There's a national drive for more new doctors to come in. National and local drive around retention and return of experienced GPs. So we do quite a lot to try and fund that locally. And then a higher priority as well for primary care in housing developments. And we already work closely with the local authority around some of that stuff, but there's opportunity to do more in that space, I'm sure. And then the fourth area is around cutting bureaucracy. So this is how primary and secondary care can work more closely together. So that actually when primary care make a referral, it's got all the requirements for secondary care in terms of the information, but also that secondary care are doing what they need to do in terms of the patient pathway journey before that patient is discharged from either an outpatient or an inpatient appointment. And then nationally also, there's also a focus on trying to reduce some of the bureaucracy for general practice as well. Okay, so I've got 2 more slides, I think. So this is how we're measuring our success in this regard. So we've set some deliverables and process measures. These are specific for Plymouth. So at the moment, we've got 18 of our practices are on cloud-based telephony. We plan to get that to 23 by the end of 2024, which is really good news. I have to say, we're actually ahead of the curve in Plymouth compared to where we are in other areas. So there's been some great work. But it's not just about moving to cloud-based telephony. It's also about the functionality within cloud-based telephony as well. So I know my GP practice, for example. If it was probably about 6 months ago, I'd have sat on the phone in the morning for quite a while, waiting for it to ring. But now I know when I phone my GP practice, I know what number I am in the queue. I know whether to wait or not, depending on what number I am in the queue, and I'll get a call back if I'm so many people in the queue, and it's going to take a while, they'll call me back. So I know from my own experience that's really good. So really pleased that we're getting practices moved over to those systems. In terms of the additional roles, I talked about the additional roles that general practice are employing. We've already got 170 of those in Plymouth at the moment. We're hoping to move to 190, so that's right at this minute. We're hoping to move to 190 by the end of the year. And that should by and large cover most of the budget that we've got for this. So we get nationally a set budget for the additional roles, and our practices are doing really well with being able to employ. Again, though, there is variability. So we know in some places it's harder to recruit with others. So they're the practices that we're working with to understand how we can help support. The primary secondary care interface document I mentioned earlier on. So we're hoping that will help enable freeing up some GP capacity time, whether it's as much as 8 to 10%. There are varying different measures on this. I'm really pleased to say that our local acute provider, so University Hospitals Plymouth, are working with our GPs in the locality to really get underneath some of the detail of that, to make things as simple as possible and the transfer of patients as simple as possible for both the patient and the professionals as well, and that gives a much better patient experience for the patient as well. And then in terms of moving to some at-scale developments, what we're really conscious of is that we do know we've got practices which have some sustainability issues. That's absolutely true across the country. We are working as well with those practices, primary care networks, and at a bigger scale as well, to look at what opportunity we've got for at-scale options as well. So obviously we've got a provider in for Mayflower now. What we hope is that'll create some real sustainability. There are opportunities though for practices to be working more collaboratively together, and for PCNs to work more collaboratively together as well. And we want to encourage those conversations through our collaborative board. Okay, and then this is the last slide, I think. One more. Okay, patient experience and outcomes. So how are we measuring the experience and outcomes? So we're very much focusing, trying to focus very much on the patient experience. So as you can see there in Plymouth, our position in terms of patient satisfaction is below the national average. And we want to improve that. It's also below the Devon average as well. So we've got a target we've set ourselves, and we want to improve that. Same with ease of access to the practice as well. Again, we're under the national average and under the Devon average, so we want to improve that this year. I have to say, since actually doing these slides, we just had a message this week that the National Patient Survey for General Practice, and I don't know whether Tony's heard this as well, is actually changing next year, and they want to make quite a significant change to some of the questions. And they have said that means you can't compare year on year anymore, which is slightly unhelpful when we're trying to measure improvement. But we'll work with that as it comes through. And then the other areas that we're trying to measure are in line with the access. So we already, all of our practices meet the national standard in terms of offering same-day appointments. They all meet the national average in terms of 2 weeks as well. And as I said, we know we've got some fragile practices, and we're really trying to reduce that with the work that we're doing with them over the next 12 months or so. I think that's my last slide on general practice. Oh, right, sorry, no, one more. So, and this is important actually, because this is just an overview of very much what I've talked through is a bit of the process and the metrics and things. This is some of the more improvement work that we've actually been actively out there doing. So there was an improvement week, a general practice improvement week, which was joined by multiple partners. So it wasn't just the primary care networks that took place, but we had 2 of our big primary care networks did take place. That took place in the week commencing the 25th of September, and it was really focused, and it was a real QI deep dive into some areas where we felt we could get some traction and really try and get underneath and free up some capacity in general practice. The evaluation is underway at the moment. I haven't seen the results of that, but my understanding is that those primary care networks got a lot out of that. As part of the National Primary Care Access Recovery Plan that I've just talked through, the national team are putting on a lot of events and training and also specific support to practices, and we're encouraging and signposting all the Plymouth practices to sign up to those, and we've had some good feedback so far from some of those, and that will really help them in terms of how do you make best use of your additional roles, how do you manage your demand and capacity, how do you do your triage. So it's really practical stuff that's in there. As part of the same process, we are running capacity and access plan visits. So every single primary care network has had to come up with an access improvement plan and details of what they'll do and when they'll do it. And we're actively out to all the practices, visiting all the practices to work alongside them to understand how we can help support that and make sure we've got the right actions in those improvement plans. And then lastly, I already mentioned cloud-based telephony. So Plymouth are already ahead of the curve, as I've said, but we are supporting the remainder of those practices to move to cloud-based telephony. And Elliot, I think that was the last one. Yes. So happy to take any questions.
Thanks, Joe. Alex, do you wanna say anything before I take questions from members?
But there's just a couple of things I can maybe just add to, if you don't mind, Chair. So just firstly with the deep dive, as Joe said, it's kind of being evaluated at the moment. So I don't have kind of the full kind of results of that, but I have seen a couple of emails from primary care who felt that it really did make a difference to them. So that sounds really positive, and hopefully we'll understand more about that in due course. The second thing was just with regards to workforce, and I'm not sure whether we know in kind of Devon and Plymouth in particular at the moment, but nationally there seems to be a real sea change in kind of people's career aspirations with regards to general practice. And I think it's partly because there are more of these additional roles like paramedics and pharmacists in general practice. There appears nationally, I've heard this from lots of places, to be less kind of work for locums, for GP locums. So people are kind of looking at their kind of careers a bit more. And I think we'll probably see a bit more of a shift nationally away from people locuming and perhaps being kind of more salary GPs or even partners in the future, which is good on a number of levels, partly with regards to kind of continuity of care and general staffing in practices, but also there's I think there's a financial benefit to patients as well, because locums do a really good job. A lot of practices need locums. My practice needs locums, but sometimes because we don't have any option, we're spending more on locums than we would as a salary GP. So it just releases a bit more money into practices. And then just the final thing was with regard to the primary secondary care interface document. So this has been a long time coming, and again, for those of you that have had conversations with GPs across Devon, it's something that's on everyone's radar. There are lots of things that historically have happened in secondary care that have moved over to primary care, and none of it's been done with any malice, but sometimes there are things that could be done differently in secondary care that frees up our capacity in primary care. So a really good example is, and again, just through custom and practice, historically, if someone had an operation and would need 6 weeks off work, kind of post-operatively, a hospital might just give a sick note for 2 weeks, and then the patient would have to come and see their GP for an extension for another 4 weeks. But one of the things that we're addressing in the primary secondary care interface document is about saying that actually hospitals can you do a note for 6 weeks, so actually an appointment isn't used up, and someone else can have the appointment. And that's just one example in the document, but there's 10, 15, 20 things in the document, all of which should make a bit of a difference to primary care. And also there are some things that in primary care we do that affect secondary care. So it's kind of setting some principles for us kind of wherever we work in the system. So we've very nearly got that over the line, and that should be published before Christmas, I'm hoping.
Thanks, Alex. Before I go to other members, just a quick question from me. It was interesting that you said about like using pharmacies for things. Can I just ask about these physician assistants that made news last night about these physician assistants? I don't know if anybody else saw that last night on the news. I'd never heard of this. So can somebody just tell me, do we use them? I mean, I honestly didn't know anything about these, and it's a bit worrying if we kind of like see that on the news. And as a health health committee that I didn't know. I don't know if any of the members had known that there was physician assistants. I don't know, but I certainly didn't.
I'll let Alex take that one.
Yeah, absolutely. More than happy to answer that. So they're called physicians associates, and they have been around in other countries, predominantly the States, for years and years and years. And essentially, their role has been to kind of assist kind of doctors in kind of doing the work that we do. And they do a number of things. So I think it is slightly different in different countries, but they will see patients. They can't prescribe at the moment, and they can't order things like X-rays, because there are various kind of national rules and regulations around them. But there are various services and countries where they're felt to be very beneficial. Now, I think. I didn't see what you were referring to in the news yesterday, but I am very aware that there are some concerns from doctors and some others about their kind of competencies and what kind of patients they could be seen and their supervision. And I think these are all really important questions that people are asking. So I don't know, Joe, do you know whether any GP practices in Devon have physicians associates? I certainly know that we're having them coming through as students, because there is a student program that I think is based out of Plymouth, I think out of the university in Plymouth. So they are coming through our secondary care providers. They are spending time with us in our GP practices as well. But there are some questions kind of nationally about how they whether and how they should be regulated, like doctors and nurses are, and actually about what types of patients they should see and what kind of supervision that they should have within GP practices and elsewhere. So I think it's important. I suppose in summary, I think it's important that these questions are asked, and I'm sure we do have some, at least in secondary care, and we certainly have them coming through as students in primary care. But we need to make sure that actually it's done safely and they're seeing the right type of patients. And I think, to be honest, a lot of these questions need to be sorted out kind of at a national level, rather than something we can do in Devon.
Thanks, Alex. It's just that I know when it was mentioned last night on the news, I think they were saying it was they got about 3,000 and they want to increase that number to about 10. And that's quite worrying. When, like yourself and people like John, have had to do many, many years of training, and that they only need to have 5 years of training. So it is quite worrying.
Yeah, I think so I understand the concerns, and I've seen some of the sort of media around this, but I think Alex is right. It's about asking the right questions, making sure there's a real structure to support those individuals, so the training, the support them within the practice. And I don't know whether we've got any in Devon or not at the moment, and just being really clear about the cohort of patients that they're seeing, and the expectations on them in terms of what their remit is, because we know we've got huge workforce challenges. It's just about making sure that nationally they've got some of those things right, I think.
Thanks, Joe. Lee.
Oh, thank you, Chair. Speaking to you now as Chair of the Patients Participation Group for the Mayflower surgery, so we're well aware of what's actually going on here. But I just want to bring some points that you've alluded to. Unfortunately, due to regular visits in A&E, I was speaking to a consultant one morning after an admission, and she said that 30% of their capacity is being used up because people can't get to see a GP. So therefore it's putting undue pressure on the hospitals. The second thing is patient experiences. Mayflower Group have basically hit the floor. They can't go any lower. A lot of patients have actually turned around and said, with regard to F&F, who are they? How were they selected? How many bidders were there for the contract? And actually what they're going to do differently. The patients haven't got a clue. We know that the management's changing. Now, the bizarre thing with the management is we had a meeting the other day discussing the Patients Participation Group direction and input of a new committee. And one thing that came to light is in 1 minute on the Monday, we're talking about Livewell have got the contract for the next 10 years. And on the Tuesday, we get an email from the council to say Livewell hasn't got the contract and it's gone to F&F. So there's total confusion with regard to both patients and management within the organisation. Appointments, when you talk about appointments, what some of your charts are showing and what we've been aware of is that it's doubling up of appointments. For example, if you get push doctor, a push doctor can't actually physically see you. He can't give you the medication either. He then has to refer you back to another GP, but that's 2 appointments. Well, under the summing up, regard to appointments, that's classed as one appointment and not 2. So we notice there's a huge discrepancy in the amount of appointments actually available to patients and what isn't available to patients. One of the biggest and primary problems that we have is access to GPs. The only way you can access Mayflower Group GP surgeries now is via e-consult, and that's driving a lot of people to A&E as well. They're getting halfway through the e-consult, they end up writing an essay, they're on a lot of medications and whatever. It could take them an hour, whereas to get on the phone. But then to try and get on the phone, they're also subject to 60 minutes, 120-minute waits, and people are giving up. So people in urgent need of care aren't getting the care. And one thing we actually discussed was minimum staffing levels in surgeries. And the general consensus is, and this is from the medical people within the surgeries themselves, I'm not going to allude to names, is that you need 2 GPs, 5 days a week in that surgery. Debatable whether you need a paramedic, but a nurse and a receptionist. That when the contracts are going out, they're not actually taking account of one simple fact, the basic necessity of staffing levels for a GP surgery. In fact, the last contract was awarded and there was no money for actual buildings and maintenance, meaning that money was being withdrawn out of patient care to actually service the needs of the buildings, which they don't actually own. So, you know, can you give some assurance here to the patients of the Mayflower Group, to this committee, and to the communities that we represent? Because as you know, the Mayflower Group is citywide. We've got Mount Gold, we've got Manor Mead, we've got Stirling Road. Unfortunately, you decided to close down Chard Road and Collins Park, which busted the back of Manor Mead. That there is going to be adequate GP provision to meet the needs of the population that we serve, and I serve as a chair of the Patients Participation Group. So I can actually go back and say something positive to them, please.
Yeah, happy for me to respond, Chair. Yeah, thank you, Lee. I really appreciate that. And funnily enough, I was speaking to Fuller and Forbes this morning, and he quoted back to me some of the things that he's obviously picked up as well. So they've definitely heard this. I'm going to try and take them all in turn if I can. So first one about the patients turning up to, or patients choosing to go to the emergency department. So we absolutely know there are patients going to the emergency department who don't necessarily need to be there. We know that from the recent Health Watch report that we've seen. We know that from work that we've been doing to try and unpick that behind the scenes as well. There are varying different reasons for that as well. So some of that will be about patients not being able to get access, but there'll be different perceptions about that as well. So there will be perceptions about whether a same day appointment is needed or it isn't, and there'll be a clinical view about that and a patient view about that as well. But that's not to take away from the fact that we know that access is an issue, hence why we've undertaken the procurement, and that's why we did that back along. I don't know where the bit about the 10-year contract for Livewell came from, but that's not come from us. So that was never the case. So that sounds like it's just lost in communication somewhere, but that's never something that we've said. But I really take your point about the patient experience, which is the bit that we were focusing on with Fuller and Forbes earlier on. So they quoted back to me the access via e-consults and how long you've got to spend on a phone, and that is absolutely what they're focused on improving. and they've got some ideas and they've got experience from where they've done this elsewhere. We've got really good, as I said, we've got really good experience of them from their other practices in Devon as well. So they've got another practice elsewhere, and actually their access is very good. So we've got quite a lot of confidence that they know, and they've got some robust plans that are around this. And obviously, as part of the procurement process, we reviewed those plans. We also, as part of the procurement process, and we did last time as well, but others won't see this because it's not in the open forum, but we had details in terms of their staffing model as well. So we have seen all of that. So we do get a chance to review that and quality assure that as well. In terms of the bit about the buildings, so it's different in different practices. So some practices own their buildings, some lease them from sort of third parties, etc. But we do cover the rent for those buildings as well. So there is, so it isn't true to say there is no opportunity, if you like, within the core contracts. Within the core contract, it should cover being able to kind of keep up with some of the need for that sort of refurbishment and keeping your buildings. But we do know nationally that estates is a huge problem in general practice. So some practices are in really old buildings that are just not fit for purpose anymore, and that's obviously been a nationally recognised issue through doing the PCN toolkit work. And I think the other thing you said was about counting of the appointments, and that's what's really important, that data we're looking at, we need to start somewhere. We need to be looking at the data. We need to be talking to practices, but we know that data isn't perfect. And nationally, they haven't defined some of those things. So how do you make sure that you're not counting things twice? Or if you are counting them all, are you making sure you're accounting them in terms of what's the initial contact? Is it an initial assessment that you're getting? Is it a follow-up? So that's really important, and that's the work that we're doing as part of the primary care access visits with practices, to try and get them to understand their data better as well, because they'll all be submitting it in a slightly different way as well. So I feel very confident, having gone through the procurement process with them, the new provider, I feel very confident for the future. We've subsequently had, as I've said, assurance meetings with them, and we still feel very confident about that. And next week, I'm not quite sure what day it is next week, but we've got a very specific session, and Fuller and Forbes are going to come and meet with you as well, and we've got a virtual session next week, so we can test that out more fully.
Supplementary.
Yeah, I could just follow up on that. I think to really summarise in a very simple way, but factual way, is to say that 5 years ago everything was working within a reasonable context. People could get an appointment with their GP. There was not the problems you got now. So what has happened? I suppose the simple question is, what has happened in 5 simple years that it's all gone to the wall? Because obviously, clearly, the clinical commissioning group and the ICB have not addressed that simple thing. Historically, 5 years ago, 6, 7, 8, 9, 10, things were working adequately, and we could get there. But it's all gone pear-shaped in the last 5 years. What are you going to do to address that going forward, please?
Yeah, I mean, I think that's part of a much, much bigger conversation. So I think what we need to be clear, and I will let Alex come in a minute as well, because he'll have a really helpful perspective on this. But this is not a local issue. This is a national issue. We all know that, and that's the sole reason that primary care access recovery plan has been put in place nationally. It is a national issue. This is happening everywhere. So I think that's the first thing to say. Also, the second thing to say is we can't underestimate the impact that COVID has as well. So where we're seeing significant increased waiting times for elective care in secondary care, we're also seeing something similar in primary care. You just don't see it because they don't have waiting lists in the same way. But this is huge catch up that they're trying to do in terms of getting on top of that long-term conditions management, where people haven't accessed primary care because they've chosen not to as well, or because COVID got in the way, where actually some of that is exacerbated as well. But that is, and I know you disagree with me, but that is a national issue. That isn't a Plymouth specific issue. Alex, did you want to come in?
Yeah, thanks, Joe. I was just going to I was going to try and answer the question as to what's gone wrong in the last 5 years, and I'm completely confident that it isn't just one thing. It's so many things that have kind of all added up. A lot of them are kind of national issues, which to an extent are difficult for us to address kind of locally. Actually, just while you were talking there, Joe, I was just making kind of a few notes as to things that have changed. So we've got a more aging or a more elderly and more complex kind of population 5 years ago today than we did 5 years ago. The complexity of patients makes it more difficult to provide adequately for them within the resources that we've got. We've got issues around workforce. There are fewer people wanting to be GPs. And it's not just about GPs, it's practice nurses and other staff as well. So there are workforce issues, which again is national. It's nationally recognised. It's worse in some areas than it is in others. And Plymouth is one area in particular where recruiting GPs has been more difficult. The population, as well as getting more complex, is growing. So actually, we've got more patients to deal with, and there is a bit more funding that comes as the population grows. But actually, if we haven't got more GPs and practice nurses, and our estates are kind of bursting at the seams again, it makes it more difficult. So I'm confident that it isn't just one thing. It's several things that have kind of compounded to get us to where we are now. And as I said, it is more difficult in some areas than others, and Plymouth is one of those areas, unfortunately, where it is more difficult than other parts of the country. But on the plus side, I think one thing that I've seen, and I think Joe's probably seen it as well, over the last 6 months, last year, there's a real recognition kind of nationally that actually primary care is the bedrock of everything, and whereas actually probably if we look back over the last few years, there's been kind of any extra investment that's come into the NHS over years has probably disproportionately gone to other bits of the system, like secondary care. But the people that seem to be able to make the decisions now in NHS England, the penny does seem to have dropped, and I think we're seeing shoots, Joe, of more resource kind of coming into primary care, although it's not going to happen quickly, and it's going to come in dribs and drabs. And some of the strategies that we're looking at, like the primary care access work that Joe was talking about, the primary care estates, all of these things should come together so that over the next few years, hopefully we'll be in a better place than we are now.
Thanks, Alex. Natalie?
Yeah, just quickly to start, just based on what was already been said by Councillor Finn about Fuller and Forbes, and obviously you said that they've got sort of experience in Devon. You haven't said where they're based, fair enough, but have they got experience of working with our secondary sort of care providers, i.e., with University Hospital Plymouth, because obviously there needs to be a good linkage in, doesn't there? So that's the first question, a nice easy one. The other one was regarding the improvement week, and I'll declare an interest there. I sit on the patient participation for Parfields, and the feedback I had was that they found it very, very positive and useful, so that's good. But obviously there were only 2 PCNs that actually put themselves forward for being involved. Are there plans to introduce this again, keep this going, so improvement week next year, for example, and to encourage other PCNs to also be part of this moving forward? Thank you.
Yeah, thank you for those questions. So just to answer the first one, so the other practice they've got is in the sort of Devon County Council footprint. So no, they don't at the moment have a direct relationship with UHP. But what we will do as part of this process, assurance, etc., is we'll make sure they're meeting with all of the partners, and that will be something that they will absolutely be wanting to do. So we'll make sure that happens. In terms of the improvement week, really glad to hear that they found it positive, because that's certainly the feedback I've had. I wasn't in the sessions directly. What we want to do as part of it is to make sure we roll that learning out now. So rather than wait, we want to make sure that the learning we get from those primary care networks, we can roll that out. I don't know whether we've got plans to do it again next year or not, but I think that's a really good question. And when we get the evaluation, we'll assess, I think, the usefulness of that, rolling out what we can now, and then is it worth doing another one? Is it worth doing it with the same PCNs and add some more, or is it worth doing it with a different set of PCNs? So thank you for that, and I will take that back.
John?
Thank you, Chair. I'll try and make a number of points quickly if I could. One, the data about appointments seen within one day. Does this mean seen face to face, or does it include email responses and telephone calls? Not that they're inappropriate always. I mean, they can be very appropriate, but what does the figure mean? Secondly, is it right that practices can refuse to give even, 2-4 weeks hence an appointment face to face for somebody who might have a mole on their back that needs to be looked at face to face? You cannot deal with that by an e-consult or a push doctor appointment, which I know has been offered. And of course, then it will result in a second consultation, which is presumably then included in the total number of appointments, when actually one appointment could have solved it all, particularly if it wasn't urgent. Thirdly, are the increasing number of pharmacists and paramedics that are working in practices compromising the ambulance services and community pharmacies? I'm coming on to pharmacies later, and I think there are huge pressures there with recruiting pharmacists. Fourthly, I think GP trainee numbers are going up. That's what I seem to hear. So hopefully general practice is becoming a more attractive prospect. And when I see adverts, which I see a lot of on the national press, not, well, actually from an agency, not just for Plymouth, all over the country, saying that all salaried GPs are expected to see will be 12 to 14 patients in a half day, and that can include telephone calls and video calls, not all face to face. And they don't do any visiting because the paramedics are usually doing this, and they've got coffee breaks, and they're being paid £11,000 a half day session per year, obviously. I mean, it is quite an attractive prospect, I think. I think lots of us would like to go back to only seeing 12 to 14 patients and not having endless telephone calls. I mean, is that what is really happening? Because that's what all these adverts state. And there are even some adverts, not in Plymouth, I will say, where they want GPs that will be purely remote, so they will never see a patient face to face, or somebody's going to have to see them face to face. What are the rules on this? So a number of points, and I wonder whether you or Alex would like to come back on those.
Yeah, thank you, John. I'll start off. I'll probably go to Alex to pick up the one that's quite specifically clinical there about the kind of, as your example, the kind of mole and the sort of, because that's definitely sort of sits in the whole sort of clinical sort of decision making arena. But just to pick up the question, John, about the same day is a really good one. So it does include face to face and non face to face as well. I have to check the e-consult bit, but it definitely does both. And there is a measure in there about face-to-face as well, so we can pick out how many are face-to-face and how many not face-to-face. And as you say, that's not, that could be appropriate, so that's helpful. We can drill that down, so that's useful. In terms of your question about workforce, it's a really good question. And I think it would be true to say that, so we know that particularly pharmacists, we know that pharmacists have moved from other roles to go and work in primary care networks. Now, that's a great thing because they're doing a great job in general practice, but it is putting pressure on other parts of the system. There's no doubt about that. So it is about how we collectively work together in that space. And that's what we're trying to encourage now that we've taken on the commissioning of community pharmacy as well. We're trying to encourage much greater links between primary care networks and community pharmacies as well, because that's the only way we can see this working, really. In terms of the adverts, yeah, I think you're right. I don't think we've got any examples of that locally. I haven't, so hand on heart, I don't know any examples like that locally. I think all of our salaried GPs work incredibly hard in Plymouth and in Devon. So I'm sure there will be examples in other places, but I think we're, as Alex said, we're under such pressure in terms of the demand for our services. I think genuinely out there, everyone's working as hard as they possibly can. There will be, and I'm sure there are, or we will be using remote GPs, and we will be doing that, and that will be part of a model as well as other things. I don't know from knowledge that we've got any practices that are specifically just employing remote GPs. I suspect that's more on a locum type basis and arrangement, or it's an arrangement as we described through Push Doctor. That would be the arrangement I suspect is more common. But yes, I'll just hand over to you, Alex, just if you want to add anything to that last one, and also just John's point as well about can you refuse to do a face-to-face appointment if it's something I suppose the clinicians deems could be done in a different way.
Yeah, absolutely. Thanks, Joe. Thanks for your question, John. I mean, just with regard to the example that you gave, if I had a photo or an e-consult that was sent in to me and I saw a mole and thought, actually, I need to see it, then I could book them in the future for them to come in and see me. I suppose one of the interesting things with this is actually, and I suppose thinking about it from a patient perspective as well. So if I have 10 pictures of skin lesions sent in to me, I might look at them and say, actually, 6 of them I can just give advice to and say, because people are often worried, and I can look at it and say, actually, that's something you don't need to worry about. You can leave it, but let us know if it changes. There might just be one that I look at and think, actually, I can't really tell what it is from the photo. So I get the patient in to see me. And there might be 2 or 3 others that I looked at and I say, or I think to myself, actually, I can see what that is, but it's not something I can deal with. I need to get the hospital dermatologist to look at it. So with those kind of 10 patients, 5 or 6 might be dealt with without having to come in to see me. One of them I might get in to see me, but the other 3 I can say, actually, I've seen it. I think we need to get it checked out by a dermatologist, and I can just get the referral off straight away. So it saves the patient from having to come in to see me at all. So I hope that answers that bit of the question. Just with regards to the kind of numbers of appointments and things, I think things are changing, and the way that the workforce is at the moment, particularly with regards to salaried GPs, they I think the workforce is moving to have kind of a towards a kind of maximum number of consultations in a day, and it's built up out of kind of learnings from airline industry and other kind of really critical areas where actually if people are too tired or too overworked, people can make mistakes and people come to harm. So it's coming from a good place, but I think it's probably different to how I trained. So I think things will change. I was going to make another what I thought was a really good point, and I can't remember what it was. So I think it is. Oh, I know what I was going to say. So I think it is training, and there are some jobs where they're quite often at. Joe might not have seen it actually. There's quite a few adverts that say actually you have 15 patients in the morning, 15 in the afternoon, no visits or 1 visit, 1 duty session a week. So people are much more aware of kind of what they're signing up to. So I think that is changing if I'm honest. But to my mind, and I suppose I look at it partly from above, but also I'm kind of immersed in it. To my mind, as a GP, there's a huge difference between seeing 30 complex, frail, elderly patients in a day who are on 6, 7, 8, 9 medications, 3, 4, 5 kind of important medical conditions, to seeing 10 photos of moles that come in on a day. So I'm stretching a bit just to make a point. So to my mind, there is something about making sure that patients are safe, making sure that clinicians are practicing safely, but we got to get the balance right and not just be looking at, and this doesn't happen, but again, just to make a point, but not just to have GPs looking at 10 really simple things that take 2 minutes each, because occasionally there are things that do literally take a couple of minutes, and it's kind of where we strike that balance. And also thinking about kind of the staff well-being as well. And I suppose I'm not just thinking about GPs. And it's important in all walks of life, isn't it? We want people to come to work. We want them to enjoy work, but we don't want to put them under so much pressure that actually they go home at the end of the day Well, actually, we probably all go home a bit exhausted, but we don't want them to get too exhausted that they think, actually, being a GP or being a practice nurse or being a paramedic in a GP surgery just isn't for me. I'm going to go and do something else, often outside the health service. And that's one of the I think that's one of the things that one of the places that we have got to in recent years. And I'm not sitting here and saying that health is far, providing healthcare as a job is far more difficult than other places, because there are other jobs that are more difficult or equally as difficult. But just the reality of the situation and what people are looking for in their work-life balance, I employ GPs because and others, I'm a GP partner, but we are having to change the model, change the way we employ people to attract people into primary care, but while making sure that we give our population kind of the care that they need to deal with their health.
Can I come back quickly on that?
As long as it's quick, John,
Yeah,
because I've got
I
two
accept the
more
thing about
councillors.
moles, but I think there are some that you can't photograph. It's on your back, and it can be difficult. And I do think actually you do in quite a lot of cases actually have to touch something to actually see. You can't see everything for a photograph. Depends on the quality of the photograph. And a final point: when practices say they can't see anyone else, or they can't even talk to someone in the day, or they can't make any communication, and they say ring 111. I mean, in my day, that wasn't an option. So people ring 111 or go to A&E. Is that fulfilling the contract obligations? Because in my day, you had to actually at least deal with it somehow, even if you rang them and said, "I'll see you tomorrow," or "What's happening?" and we'll sort something out. That's a point that frustrates a few people I know.
Yeah. Alison?
Do you want?
Oh, go on.
Yeah, thanks, John. You make a really good point, and these are things that we're talking to practices about on a weekly basis. As you say, 111's been around for some time now. Maybe wasn't when you were there, and actually we do want a conversation with primary care, not just in Plymouth but elsewhere, as to actually what should practices do when they're kind of at capacity, or if they haven't got capacity to see people. So that's work that's ongoing behind the scenes and will continue over the next few weeks.
Yeah. Thanks.
Thanks, Alex. Alison?
Thank you, Chair. A relatively quick one. You described the West End hub replacement, bringing the three surgeries that aren't fit for purpose currently together, as being a top priority when the new CSR happens. When the new CSR happens, we're going to be on the verge probably of a general election within 6 months. Government will want to have spade-ready projects. Those are the ones that are going to get the money, quite frankly, at that point in time in the political cycle. So how close are we to being oven ready? Is the turkey still in the fridge, or are you at a point where you have land identified potentially? I'm not asking for the site specifically, but are you in that place, or are you a little bit further back?
Yeah, I think, Alison, so obviously we're doing this work with all the primary care networks across Devon, and some are further along that than others. As we know, we've been working with these practices for a while now, and we've now lost that opportunity for that site for reasons that we've gone through before. So I think that has put us further back in this process. Absolutely it has. And I don't know whether the solution that we will have will be one that will still be for all those three practices we identified, whether we'll need to work with ones individually or a couple of them together. We're still working through those options at the moment, but I completely take your point about needing to have something spade ready.
We did have Zoe, but she's not here, so I'm just going to go to Kathy.
Thank you, Chair. I'm concerned about the increasing level of encouragement to communicate online, particularly for elderly people. Some elderly people still are on analog telephones. They might get a call back if they're sort of 30th in the queue or something in 2 or 3 hours' time. If they're ill, they might well be asleep by then. And so, they don't get a call back at all, or they don't feel they've had a call back at all. So how are you going to cope with elderly people who don't have computers?
Yeah, I think it's a really good question. That's why the access recovery plan is multifaceted. So it's not just about online, e-consult, etc. It's also about the cloud-based telephony, which, appreciating what you've just said, I think is a lot better than the solutions that some practices currently have, which are on analogue solutions. So, but taking your point about what you said, and there has to be a balance. So there will be patients that want to access general practice remotely, and that's fine, but there will be there would be patients that still want to and need to speak on the telephone, and that is our focus, is making sure that they can get through on the telephone, and that's the focus of the National Primary Care Access Recovery Plan, is that they can do that. And I'm really pleased to hear, when I met with our new provider, what will be our new provider in Plymouth, that is a focus for them as well.
Thanks, Joe. I'm not going to take any more now, where we have to move on. I'm sorry. As Zoe's not here, I'm going to move on now. So thank you, Joe. Thank you, Alex.
Thank you for having me.
Thank you.
And I know you're staying, so okay. So we're going to go to item 8, which is the Health System 100-Day Challenge, and I've got Chris, Morley, Katie. Katie.
It's just
Oh,
me,
it's
Chair,
just
please.
you, Chris. Oh, you drew the short straw, my lovely. Thanks, Chris. Lovely to have you here.
Thank you. Yes, so unfortunately, Katie's been caught up in something urgent today, so hasn't been able to join, so it's just me. I've got some slides that give an overview of the programme of work that have been shared as part of the pack. I will just share those with you on the screen and pull out some of the key points. Just bear with just a moment. So just as a bit of a context, the purpose of bringing this today was to give an overview to the committee of a programme of work under the 100-Day Challenge that we've been undertaking to improve navigation around urgent and emergency care within Plymouth. So it's part of a broader piece of work that's been commissioned and supported by the Devon ICS across the Devon system, and it followed an event back in September last year where all the urgent and emergency care leads across the Devon systems were brought together to look at understanding what the current challenges that we've got and what some of the changes that we could do to improve the position. And there was a general consensus across everybody that the biggest impact that we could do was to look at how we can improve navigation, so how people access services to keep them away from the emergency departments, and a particular focus and agreement to prioritise Plymouth in that work, recognising the particular pressures that we face and that we've spoken through previously. So what this built on was having a sort of more of a testbed approach. So as a system, as a health system, social care system, we often, so we're very good at developing lots and lots of plans to respond to the pressures that we've got. But what looked at was actually how could we bring a different approach to this that's really based on understanding what the problems that we've got are, picking out some key aspects of those and undertaking some tests of change to start to drive some of that forwards. It very much links back to the maturity work that we've done as an integrated care system. So that was completed back in 2022 and again repeated in 2023. And what that demonstrated on both occasions is that as a system, our biggest challenge in the area that we most need to improve is around system leadership and partner relationship. So what we wanted to do was, in developing this programme and taking this forward, find opportunities that enabled us to build on that. This then works on what we've taken is the 100-Day Challenge, which is developed by the Re-Institute, which I'll talk through in a minute, and Outward Mindset as well, which I'll describe, and just take some of the 5 areas that were identified as biggest opportunities and brings them to this programme of work. And just to say, the work itself's been funded by NHS England, so it's been supported nationally as a priority, and it's been endorsed by the National Urgent Emergency Care Lead. So there's a real focus and support around this. So it started with looking at some diagnostic work to understand what the particular areas of focus were that we needed to develop. And as I say, it then very much focuses and centres around how can we learn by trying. So how can we focus on some particular actions and empower people and teams of workers who are involved in the direct delivery of care in order to test ways of working and do that at pace. So the 100-day methodology is all about doing that quickly, learning if something's not working, trying something different, and just repeating that process in order to deliver improvements. The setting the agenda, change agenda, so as part of that broader work around the integrated care system, as I mentioned earlier, we recognise that there is a particular need for us to change our way of working, and it's all of this has been built around that need to shift our culture and adapt our way to enable better collaboration. So the complexity that surrounds urgent and emergency care, we can only address and change things by working differently together as partners. And that's both partners in the traditional sense between health organisations, social care, but also voluntary and community sector, who've been a big part of the work that we've taken forwards. So the next slide describes the approach that we've taken. So as you can see there, it brings together a number of different change methodologies. So the outward mindset that's been commissioned as part of the integrated care system to shift our approach in order to make improvement. The 100-day challenge philosophy, and then underpinning all of that, the value-based approach. So bringing together all of those different change programs that we've got in order to deliver something different locally for us. In terms of the conditions for success, so this that describes the 5 opportunity areas that were identified through the diagnostic work that was done initially. So you see the first one, learn by doing. So as I mentioned, the 100-day challenge approach is very much about how do we just get on and test some stuff in order to see how that can make a difference. Prioritising work, so the teams that we've developed and have been taking forward the 100-day challenge have focused on a small number of things within their areas, and I'll give you a flavour of some of those in a minute, and just been empowered really to get on with those rather than writing lots and lots of plans and detailed project plans and things like that, actually just enabling them to get on with trying some different stuff. The shared purpose, so the Reinstitute organisation have supported each of the teams in agreeing some shared goals, so between them actually having priorities that they've all signed up to as a group. And that's also where it's been really valuable having VCSE and people with lived experience as part of the project groups that have taken place as well. That actually where there's been, we've seen in the goals that have been set in each of the programmes, where there's been a difference in opinion or those people with lived experience that actually, from my experience as a priority area, that's not an ambitious enough or a strong enough goal. That's shaped it. So it's been really genuine, really positive. So trust and collaboration, that's where the outward mindset work comes in. So that's very much about how do we work collectively together, how do we hold each other to account. We've got a little bit more detail on that in a moment. And the system focus, so it's absolutely been supported by all system partners locally within Plymouth as a priority and something that we've taken forwards. So the outward mindset is a programme of work that's been commissioned and supported by the integrated care system across Devon, and it's very much in its simplest form is about how we see people as people working within complex systems and organisations and bringing them together to harness the potential of collaboration. And it's about actually how do we stop looking at things individually through our own view, but actually looking at through others' views as well. And as part of this programme through the 100-day challenge, it's been a key part of this and something that each team's been supported with a training programme and a facilitation to keep that focus in terms of that outward mindset approach. The Reinstitute work, so that's where the 100-day challenge methodology has come from. It's something that's recognised globally, so there are global organisations who support many different health organisations and other organisations across the world, and their focus is very much around as I said, those short, sharp pieces of work, learning by doing, but also that actually the value of it is as much about the improvements that you can make around those particular areas that you're working in, but also changing the approach and training people who are delivering those programmes of work, the value that that can then bring in terms of how you do then take forward further projects after that. So it's very much about embedding a way of working as well as actually delivering improvements in particular areas. It's benefits for both. And the other thing that it does is it helps hold up a mirror to organisations. So what you see, and by applying the 100-day challenge approach, bringing the outward mindset work together, it helps you see where there are challenges within those teams that are working. That's often reflected in challenges across organisations. So by sharing that learning and the outcome can help us in terms of understanding our improvement and how we work better and more collaboratively together in future. So the timeline that we're working to, you can see there. So the 100 days are underway. That commenced back in the summer. The stage that we're at now is very much in the delivery of that. So the 100-day concludes on the 20th of December. So we're almost there and in that at the moment. And we're very much starting the process, and we'll be starting the process in terms of the evaluation and learning of that. There's a sustainability workshop that's taken place today and tomorrow, and that's looking at actually how do we sustain the work that's been done to date and start to scale that further. There's then a next steps workshop taking place at the end of January as well. So we'll be bringing all that back together in terms of linking the system leaders across the system who've endorsed this programme of work and looking at what the learning that we can take from it is. This just describes some of the governance and escalation. As you can see, it links into the local care partnership. So very much this is a partnership approach that's being supported by the ICB, University Hospitals, Plymouth Live Well, and Plymouth City Council in terms of having the right partners and oversight of these programmes of work. We've had regular updates into those groups too, and that's where the output we reported to, as well as then reporting into the wider Devon system architecture as well. The evaluation work is being supported by the Academic Health Science Network. So they've been part of the programme as it's been developed and taken forwards, and they'll be turning all of the learning and the outputs into a learning report. It's not going to be an academic piece, it's very much about having something that we can take the learning out of and give us a clear implementation plan. So how do we replicate this in other areas? So that's kind of the methodology behind the evaluation, and that's something that we'll be able to share once that's concluded. So now just to give you a little bit of an overview in terms of the areas of focus, what the teams have actually been doing. As I say, they're well into the 100-day challenge now, and that's evolved as time has gone through. But back at the outset, what was undertaken was initially some discovery calls. There was 40 of those with different senior leaders across the Plymouth system who are involved in urgent care, just to identify what some of the key challenges and areas of focus should be through the 100-day challenge. That then culminated in a workshop that brought together senior leaders from across organisations, and we narrowed that down to 3 key areas that we would focus on, and 3 100-day challenge teams were set up. So those are tackling avoidance admissions from falls, tackling avoidable admissions at end of life, and improving care for people with long-term health conditions. So just to give you an overview on each of those, we've got those within the packs in terms of what some of the key highlights that have come out for each of those programmes of work. You can see there in terms of the goals. So for falls, it was very much about a targeted approach to increase the number of people aged over 65 who remain in the community after a fall without an injury by 30%. So how do we support people to stay at home rather than going into hospital? So it's been really positive in terms of the output of that. There's been a real commitment and enthusiasm from the team. This is replicated across all the teams who've been involved, actually having that time to be able to come together collectively and empowerment to actually try and do some things differently. It's been really positive. It's also helped to break down some of the barriers between organisations, so bringing that outward mindset and the training that took place has helped from that perspective too, to make sure that we've got the right people in the room and they're working collectively around the goal. The Falls team programme itself, so it's focused on a number of things, but just give you an example, working with some of the false response the alarm services, so that actually they can get referrals directly into some of the services that we've got in place in order to maximise the impact that we've got. It's something I spoke about when we came to talk about the winter plan a couple of times ago. This has very much helped take forwards some of that. And you can see there's data set there that's been set up through the 100-day challenge processes as well, so that we can see what impact that's having, and we've seen some positive outputs from that already. End of life, so their goal was around having the right support to make sure that people have a good death in their care home, where that's where they are, reduce the number of patients at end of life who are conveyed, so transferred from a care home into hospital, by 10%. So the work around this area is focused particularly around care homes, working with some of those key care homes, and having visiting teams who've gone out to understand some of the challenges they've got, share some of the support arrangements that we've got in place, and build some networks in order to take that forwards further. I know at the February's overview scrutiny committee, we've got a focus around end of life, so certainly we'll be able to share in detail some of the learning that this has helped inform in terms of some of the work that we've taken forwards. But already it has helped in terms of understanding with some of those key homes actually what are the things that we can do differently, bringing together work collectively between UHP, Live Well Primary Care and partners to look at cases where homes have transferred people at end of life, and to see what we could have done differently in order to support them. So that's been helpful, and also enabled us to think about different training offer and support that we can take forwards. And then the last one, the long-term conditions. So this one was looking at actually how we could improve care, targeting 50 people with long-term health conditions living in the city, in order to have a more integrated information system. So primarily it was looking at how we would use System 1 as an electronic database in order to support a better way of referring and connecting people into services, and particularly work between health partners and organisations, the voluntary and community sector, and using those assets that are within local communities. That was quite complex in terms of data governance approaches. But separate to that, what they then identified was opportunities using something called the Joy app that's been commissioned across Devon by the ICB, and actually giving access to some of the enhanced capabilities of that to voluntary and community sector partners to enable some direct referrals to take forward. And actually that in itself has been really successful in terms of actually enabling better oversight and understanding of the resources and the opportunities that are there for individuals who are presenting within the health system, and then enabling a quick way to refer them through. So as an approach, that's also then enabled those teams to work more collectively and start to build a better understanding of how they can support each other. So that's kind of a very whistle-top tour of what have been huge pieces of work in terms of the work that's been taken forwards by under the 100-day challenge in each of those teams. I think some of the key things, the learning that we've had has been really positive and will help us moving forwards. Really happy to come back and talk further around it, around the particular areas once we've concluded the 100-day challenge and when we've got further detail around that. But keen to hear from the committee today if there's particular areas of focus that they wanted us to follow up with those teams who've been involved, and think about how we bring that in future.
Thanks, Chris. Just a couple of things. When you've talking about end of life and you've gone into 11 homes, and you've gone to 9, you've visited 9. Can you tell me who did you actually speak to into these care homes? Was it staff? Was it residents? Who was it that you spoke to? And the other bit is my concern is about the TEP form, the treatment escalation plan. You're saying that it needs to be updated. Can you just tell me what you mean by it needs to be updated?
Sure, thank you, Chair. So in terms of the conversations that have taken place, they've been in the homes themselves, so the teams have gone out, often in groups, into the homes themselves, initially speaking to clinical leads in terms of the nursing homes, having those conversations with the staff who are directly delivering support, some of the carers. I know in some cases they have spoken to residents within the home and family members as well, and particularly that's something that they followed up through those kind of case studies and work that they've been doing. So there definitely is a link back, and that's absolutely part of the approach that we've been keen to take in those homes. I should say, so those homes particularly were identified as homes that, looking back at the data, had had the highest number of attenders of people at end of life into ED. So it's focused around that, but many of the themes have been the same, so it's been quite helpful. In terms of your question around TEP, so it's more around making sure, and the learning has been actually where people's needs and presentations have changed and they might have had input with services. Is that something that's been back and looked at in terms of what the plans are, and making sure that's always done and embedding that, and the opportunities through the electronic TEP as well. So how do we make sure that it's more readily available for practitioners, and that's embedded as part of that standard process? So that's sort of where the focus has been around that.
Okay, because my experience with the TEP form is, I mean, you could ask me, I might have the onset of dementia, and you could ask me what I'm going to have for my tea tonight, and I could tell you, but actually, I might not be able to actually understand what you're saying to me about a treatment escalation plan. So I think it's really important that you involve relatives, and it's kind of like a grey area, because if you feel, or medical people feel, that that person is capable of answering those questions themselves, relatives don't get involved. So I've kind of like, I'm a little bit concerned about that, because through experience, that's what's happened. So I am a little bit concerned about what we're going to do to improve the TEP plan. I'd like to know if, you know, what we're actually going to do about that. So I have got concerns with them.
So if you're happy, what we could do as part of the Overview and Scrutiny Committee in February, with the focus around end of life, I can have a conversation with the team about how we could bring an update around that and answer some of those questions, if that's helpful.
Yeah, that's brilliant. Lovely. Thank you, Chris. I'm going to go with Paul, Alison, and then Lee.
Sorry.
Thank you, Joe. I'd just like to know, you said it got funded by NHS England. How much we got and spent on all this, please?
I don't know. If Katie was here, she'd be able to give you the answer. Apologies. I can find out and let you know.
Alison?
Thank you. Page 59, 100-day challenge, end of life. One of the learning bits talks about poor awareness of systems such as DCCR, poor access to hardware. Would the care homes themselves be responsible for purchasing more hardware and training people in order to use the hardware? And obviously at the moment with money issues, a lot of them aren't going to do that. And yet it would appear that that potentially could lead to a saving or an improvement in the way end-of-life care is managed to the NHS. Has any recommendation gone into the NHS centrally or into government to say, you know, this is a small amount, perhaps it's something that it would be cost effective for us to help to fund?
So certainly something we'll be picking up as part of the evaluation of the learning that comes out. I mean, I think there has been quite a bit of investment. So through COVID, NHS England supported us in purchasing tablets for care homes, a number of tablets for care homes. We've also commissioned a service called a Medicare, who provide clinical support to care homes, and as part of that, that includes the provision of a laptop. So there's things that we've been doing in terms of some of the support arrangements that we've put in place. But I think you're absolutely right in terms of, you know, there is more that we need to understand around actually what are some of the opportunities that hardware and tech can bring in this space, and take the learning from that. But also sometimes it's about, you know, there are so many apps and different ways that we can access stuff that simplifies it. So actually making better use of the kit that's already there, but perhaps looking at different ways that we can approach that. But absolutely that will flow out in terms of the learning that we have.
Lee?
Yeah, thank you, Chris, for your presentation. I've got to be honest, it reads very much like an academic thesis. And it's symptomatic of the problems that we actually face. In layman's terms, I think it's overly complicated. It's just reinventing the wheel. let's say historically nurse, GP, contact point, signpost, hospital, pharmacy, district nurses, community, hospice, maybe Macmillan. Yeah, so there's a gateway there and direction from a single point of contact. I think once you make it overly complicated for people, and I think, you know, trying to understand this here is like, what's all this rubbish about ED, front door triage, kiosks at the front doors to triage low acutely patients more up to appropriate services. So what you're going to do, stop people from coming into A&E now? Put somebody on the door and say, you can't come in here because I think you need to go to a pharmacy. I'll give you a typical example, tummy pain, right? Seems innocuous enough, doesn't it? Oh, just go to the pharmacy. Leaking lymph nodes, cancer, 3rd degree cancer. Because they couldn't get through the front door, all right, because the triage indicators or the tick box would say, oh, you've got a tummy pain. That fits in with what John said earlier about different types of moles. Sometimes you need to feel them. So actually stopping people at an ED front door, I think, is terrible. What Derriford has done there, and I think is really good, is that they've integrated a minor injuries aspect to it. So for acutely unwell people that come in via ambulance, they go to the right, and they go to minor injuries to the left. So they have done a separation up there, and that does appear to be working quite well. When we talk about mental health triage, we all know that the mental health in Plymouth is in crisis. I only heard last week of somebody who was acutely unwell, couldn't get any help from mental health services or the police, and was subsequently found hanging because they couldn't get access to it. So, you know, until these areas are actually tidied up and you're actually sure where you're going to signpost people, it's a 100-day challenge to actually, I think, come back to basics. It's just a personal point of view, is to come back to basics and say we need to revisit this and at least get the fundamentals right before we actually proceed. Thank you, Chair.
Thank you, Lee. So certainly, just to clarify, those particular ones were kind of examples of, they're not necessarily things locally, but it was more around. But yeah. So the focus of the 100-day challenge is more in those last few slides, that they focused around the particular areas and those goals. But you are absolutely right, Lee. It is about. It is such a complex system, isn't it? And the number of different organisations that are part of it, and the whole approach of the 100-day challenge is, how do we bring the people who are working in it together and just get them to focus around a few simple things, of what are the small changes that they can make and test in order to simplify it for people. So it's very much, I mean, yes, it's like going back to basics, but actually how do we do that and unpick some of that? Because the difficulty is when we look at very, very complex and big pathways, a lot of that can then get lost, and you run the risk of making things overcomplicated. And so it is very much about how do we kind of cut through that and make that as simple as possible.
Okay. Thank you, Chris. Thank you for coming in, and it's been a pleasure having you here all year. Hopefully we'll probably see you in February, I expect. And just wish you and your family a lovely Christmas, and we'll see you in the new year sometime.
Thank you.
Thank you. Item 9, community pharmacy. We're going to have Joe, Alex. Have we got the others? Stephen, Melissa, and Joe, and David. But I don't believe we've got some here with us.
Yeah, thank you very much, Chair. Again, we've got the presentation, which I'm hoping Elliot can pop up. I'll try and, as I said, like I tried to last time, although it took longer than I anticipated, try and whiz through it quite quickly because I know you've all seen it. And Melissa is here. I'll ask Melissa to introduce herself. She's a member of the primary care team. Melissa?
Hi everyone, yeah, Melissa Redmayne. I'm the Primary Care Commissioning Manager for the ICB.
Thank you, Melissa. And
David Bierman, I'm the Strategic Lead for Community Pharmacy Devon, formerly Devon LPC.
Great, thank you. Yes, you asked us to come here to talk through, I think, probably it came from a came originally from a concern about some pharmacy closures, but wanted to sort of focus on the overall picture, really, some of the key issues, some of the challenges we have in community pharmacy, and then what we're trying to do collectively, which is why it's brilliant to have David here as well. Okay, so Elliot, thank you. Okay, so I'm not going to go through all this because you've, as I said, you've seen the slides before, so I'm not going to focus on all of this. But what this does represent is, over the last kind of 18 months or so, a real, I suppose, more focus, I think, from the national team in terms of the role of community pharmacy. I think within some of that documentation and publications which have come out, I think community pharmacy has been represented in some of that, though to a much lesser extent than in some other areas. So I think although it's recognised that community pharmacy has got a big part and big part to play in terms of the overall system, I think we are encouraged to see that. However, there is a lot more to do in terms of focus around community pharmacy, both nationally but also locally as well. I talked to you earlier on about our primary care access recovery plan. So community pharmacy is part of that access recovery plan, and what community pharmacy can do to contribute to that improving access in the wider primary care picture as well. Some of those things that are on there, some of those opportunities around things like Pathfinder programme and minor ailment service, we're going to touch on in a moment anyway. So I won't majorly dwell on that now, but I do just want to pick out the last one there as well. So the Plymouth School of Pharmacy, so linked in with Bath University. The first intake's in September 24. So that is really good news for this region. It's been a long time coming, I know, and a long time fought for, but that's really good news for us locally to start tackling some of those workforce challenges that we talked about earlier on in the primary care access recovery plan. Okay, so just want to give you an overview of the current pharmacy situation. So this is across Devon, so this is not just Plymouth specific, but I do think it's reflective of the local position as well, which we'll come on to in a moment. So overall, we've got a total of 222 pharmacy contracts, what we did have as of May 23. That predicted number is predicted to go down. So we know we've had contract handbacks already from Lloyd's Pharmacy. Now we've got Boots as well, which we'll focus on in a moment. Not only has there been a reduction in the number of pharmacies that we've got, but there have also been a reduction in some of the hours as well that those pharmacies are able to provide as well. What's interesting on the bottom table there is we're predicting that we'll move from a position where the majority of the community pharmacy contracts are led by multiples, owned by multiples, and that actually we're predicting that changes over in the future as well. So that's quite an interesting area, I think, for us to focus on in the future in terms of how we work with our partners in community pharmacy. Okay, so some of the challenges, as I said, I'm not going to go into this in finite detail because you've had the presentation, had a chance to look at it, but we know finance is a significant challenge here, just as it is for general practice at the moment. So overall, there's been flat funding since 2019. The changes as well in the way that community pharmacy is recompensed as well has changed as well. So a lot of that is very heavily focused now on clinical services. So you'll hear and you'll know that pharmacies are doing more and more in terms of offering different services, but that isn't additional money in. That was part of the overall funding envelope, which has now been focused on delivering a set of clinical services. So, and what's really important in that as well is that's, of course, that's a big issue in terms of sustainability of community pharmacy, but that really needs a partnership approach as well. So community pharmacies are very reliant on referrals from other parts of the system, so general practice being one of them, but also working with acute providers as well to make sure that they get those referrals and get that business through the doors. And I'm sure David will talk about that a little bit later on. Perhaps as well, but that's a really important area for us to focus on in terms of future sustainability of community pharmacy, is really focusing on some of those clinical services that they provide or will provide in the future and how we can support them to do that. So we know workforce in this area, just as much as any area, is a significant challenge. We mentioned earlier on the additional roles in general practice, and John, you're absolutely right to point out that there's pressure here in between the additional roles that general practice have recruited to, and then what that means in terms of knock-on consequence and impact for other parts of the system, community pharmacy being one of them. So that is a tension that we need to manage. And the only way to manage that is to try and work more closely between primary care networks and community pharmacies. I've mentioned the Plymouth School of Pharmacy, so I won't mention that again. In terms of access, some of the challenges have been around workforce shortages, but also some of those financial challenges as well have resulted in some permanent closures, which we're now seeing as well. There is a real lack of digital integration as well, which means it's not always easy to streamline communication between community pharmacy and general practice as well. So that is a real area. It is an area of challenge, particularly when we're talking about those two services, primary care services, needing to work so closely together. And then there's something about the narrative as well, which I think is really important here, because we hear a lot about the challenges in primary care in general and in community pharmacy. But actually, community pharmacy is part of the solution, as well as having its own challenges. It is part of the solution, and it's really important that we don't forget that. And actually, there are community pharmacies out there who want to undertake and take on these additional clinical services, want to do more, want to be part of the system response to some of our pressures as well. And I think that narrative is really important, that we don't lose sight of that with a backdrop of some pharmacy closures, and undoubtedly that will have some impact. But actually, we've got a lot of partners out there in community pharmacy who want to, are willing and able to work with us. Okay, so in terms of some of the opportunities, so this might be in a moment where David's able to sort of add some flavour, particularly if you've got any questions around some of this stuff. But there are, as we said, there are opportunities for community pharmacy to undertake some clinical services on the system's behalf, but also these are opportunities in terms of, for the future as well, in terms of their own sustainability as well as community pharmacy. So we've got the hypertension case finding service. That's one of those opportunities. We've already got the discharge medicines service network as well. Now, I'm not going to go into detail about these unless people want to pick up specific questions about them later. We've also got some really good pockets of integration that are already happening at the moment, and we're establishing and developing the community pharmacy primary care leads network as well. And we've also got, I think, a really good opportunity with 5 community pharmacies that have been awarded as part of the Pathfinder programme to become independent prescribers as well. So that's a real opportunity and test for us for the future as well. Okay, so what are our priorities? So as an ITB, so we started to commission community pharmacy services from the 1st of April, so took on delegated responsibility. So it's true to say that we're novices in this field at the moment. We continue to work with the existing team in NHS England, who work in a hub arrangement across all of the ICBs. They continue to support us in terms of the technical detail and some of the contracting, but we are really sort of getting to grips with this at the moment and trying to understand what some of the opportunities are as well as some of the challenges. So our first priority is to develop a strategy for the longer term, and that work's already kicked off. So we're wanting to work with partners, engage with partners, particularly our providers out there in community pharmacy, but also a wider set of engagement as well with wider partners to understand what our strategy needs to look like for the longer term. But doing that with some of the work that's been done nationally, in fact, quite recently nationally as well, to look at what some of the opportunities are that we'll have coming towards us. Second priority is to increase the resilience of the pharmacy network by maximising potential opportunities for pharmacy services as well. So very much working with them around some of those clinical services. How can we support better integration with primary care networks? How can we make sure those referrals get through to community pharmacy? We've got the access, so primary care access recovery plan, which I talked about earlier on. Community pharmacy is part of that in terms of expanding some of those clinical services. Fourth priority there is community pharmacy independent prescribers, so that's that Pathfinder programme I talked about earlier on, which gives us a potential model for the future, and also workforce as well. So obviously working with our partners in terms of what can we do to promote workforce to the area. So obviously the university is one opportunity, but here and now we know we've got a workforce problem, so how do we encourage people to stay in the locality but also want to come to the locality? And that's something that we can work with our wider partners, something we can work with yourselves on and the local authority around how we do that. Okay, so just going to talk about the current position with Boots. So Boots, as you know, has recently announced the intention to close 6 pharmacies. This is obviously in addition to the Lloyd's pharmacies as well. And then if I ask you to go to the next slide, we've got the map of how they're distributed. So the red dots on there are the ones that are due to close. We've already had one of them close already, but they are the pharmacies that are due to close. So if I can ask you to just go to the next slide, I'm going to go into a little bit of detail about these. So we are not expecting any further closures. These are the confirmed closures at the moment. As we say, we've got the confirmed one there at the top, which is already closed. We've got the confirmation of those other ones as well, and we've got details of what they're currently providing. The team have done an assessment, so Melissa, working with the NHS England Hub team, have done an assessment of the impact of that. So if you can go on to the next slide, Elliot. There's been quite a bit of detailed work undertaken. So we know that all patients have been informed and are currently starting to change their nominations to alternative pharmacies already, where they have kind of online or switching to online and postal providers, where they have those arrangements with their existing pharmacies already for repeat prescriptions, etc. So that's already happening. For some patients, we know there will be an impact in terms of additional distance. However, we've done a review of that, and the nearest alternative pharmacy to all of those sites for our patients is less than a mile away. So we're hoping that minimises the impact, and the opening hours are similar. It's slightly different at the weekends. So obviously, weekend opening is always slightly less than during the week. Saturdays, we're really happy that we've got really good alternatives, again within a very short distance. Again, that's very similar on Sundays. Again, access on a Sunday, opening hours are always shorter than they are during the week and on a Saturday. And there's only one of the community pharmacy closures where people will have to go over a mile or over 2 miles, to access the nearest pharmacy, but that's the only one. So overall, in terms of impact, we think the impact will be minimal, but that is something that we are wanting to monitor. So any feedback we get will be really helpful in terms of monitoring that. Obviously, closures that are in those areas of greatest deprivation will potentially lead to a more significant impact. So particularly interested in those areas and getting any feedback as well if people are having difficulty accessing community pharmacy. But we're hoping that the alternatives are well placed. And the impact on alternative pharmacists as well will differ depending on the number of prescriptions that they receive. So the team have been working with the alternative pharmacies as well to understand what the impact is on them. So if you go to the next slide, Elliot. We've just got a little bit of a summary of the agreed actions as well, because we have been working with those alternative pharmacies as well, which is an important part of the process. So there is a normal process for this which is followed, which includes contact being made with those contractors that are closest and understanding what the impact is on them. Most of them have come back to say that they can cope with the additional activity that's coming through. Some of them, though, are talking about increasing their own capacity to be able to deal with that. Some of them will need to see how that feels as that comes through, so we'll continue to work with them and monitor that with them. But some of them are already proactively putting on additional capacity. We continue to liaise with the pharmacy contractors to ensure safe close down process. So there is obviously a process that we have to follow, and making sure that patient transitions are happening as slickly as possible, and weekly meetings are being held with Boots as well. We're also considering what other support we can give to those alternative providers as well. So, for example, if they get an influx of additionality in there, they might need to put additional staffing on, but the funding doesn't necessarily flow from day one. So we could put in place some short-term 3-month kind of payment mechanisms to allow for any time lag in terms of additional payments as well. We're reviewing the weekend cover, which we've now completed. So broadly happy that we've got really good alternatives in place, but do want to monitor that. We're also liaising with Boots as well on the vulnerable patients. This is something we've been working with our local authority colleagues, and assurance has been provided, but we will continue to monitor those vulnerable patients in particular, and making sure that service is still there for them. And we'll continue to work with our local authority colleagues as well. We'll obviously need to consider the impact of this on the pharmacy needs assessment as things move forward, and consider whether there are any further proactive measures that we can put in place. So we are trying to identify now any characteristics where in the future we could predict this happening. So we've set up a small group to look at that so that we can be more proactive on the front foot next time. And that is it. Okay, so if it's okay, I'm just going to ask David if he wants to add anything, if that's okay, Chair.
That was pretty thorough, actually, Joe. I think from our perspective, we do concur with a lot of what Joe said in that we recognise a number of the areas in the city, actually, those closures can largely be absorbed. Obviously, this Cat Down St Jude's area is probably the vulnerable bit when we look at that in terms of activity. But as Joe says, within the PNA, we have an opportunity under supplementary statements to decide whether there is an opportunity there or not. So that will be up to us as a system to operate. The other thing I would say is actually there is some positives that can come out of this, in that the recognition that pharmacy is an integrated part of the system is quite important here, and the development of the strategy along with work around the PNA and our ability to get on the front foot and be proactive. If we can turn that into something that actually starts thinking about community pharmacy in terms of its role in the city and in terms of how it can assist with the demand pressures that are occurring here, we can potentially turn this into a real positive of all of us working together to maximise the benefits out of the community pharmacy chain in the area. But we're not going to say there's no issues in this. Clearly there are some, but I think Boots and the powers that be are doing the best they can to actually manage that situation. But I'm happy to take any further questions, really.
I mean, it's really frightening that we're actually having closures of pharmacies. So do you know what sort of impact that's going to be on the other pharmacies then? Because obviously there's going to be more people going to other pharmacies, so the queues there are going to get bigger. I don't know if any of you have been to a pharmacy lately, but I can assure you that I have. One, the queues are always long, plus people are, myself included, are having problems getting their scripts. So do you know what I mean? So I mean, I can get a text message and it'll say your prescription's ready, and when I go there, I might be 2 items short, which means that I've got to go back again at some point. So what are you doing to address all of those? Because it will have an impact on all of these other pharmacies because we've got these closures.
Yeah, no, absolutely. Thank you, Chair. Yeah, so the process we're going through at the minute, we've contacted all of those alternative pharmacies that are going to be impacted by this to undertake an assessment with them about what that means. So a lot of them have been very positive about this and that they can absorb a lot of this, but of course some it will have a much bigger impact on in terms of number of scripts than others. So some of them are already planning on putting on additional staff. Some of them will want to see how that goes first, but I completely take your point about queues. I think that is an issue, and people are choosing to access community pharmacy in a different way as well at the moment. So there will be some patient choice involved in how they want to do that, whether that's through their local community pharmacy, through some sort of online service, and some of that will play into this as well. So we don't know how that will pan out completely, but we've got a degree of confidence and assurance that we've got some adequate measures in place. That's not going to though negate what you've just said about queues already in community pharmacies, and we know workforce is a particular issue, and that's the area for us that we really need to focus on, is how can we work with those pharmacies and help support some of those workforce shortages. But particularly around the scripts, we know there are some national issues in terms of shortage of some of the medications, which we can't control locally, but absolutely aware of the impact that is having. I don't know whether, David, you wanted to add to that.
Yeah, and completely correct. There are national supply shortages at the moment that we have little control over. I know that's not helpful, but That in those situations, quite often there are discussions required between the GP and the pharmacy about what alternatives are available, and that takes that is an instant, so that may be partly driving what you're suggesting here. There are other things that are on our agenda in terms of how we may manage it. We obviously need to improve the efficiency and effectiveness of the prescription process as much as we can. And there are things such as driving up ERD and things such as that may help us in that. So that those are the type of things that we may talk about where the practices actually could benefit from increasing that. But as we say, there are staffing issues that are required here to increase the number of staff we have available. But it also may be in these instances that we need to look at something about the fabric of the buildings as well, because you obviously have a requirement for increased storage of finished prescriptions and things where you're doing more items. So it isn't just about staffing, it's about physical infrastructure as well that we need to address. I would say that obviously we are endeavouring to do what we can around those queues, and Tony's aware as well that there were some issues around the pharmacy at Derriford that are now being resolved as well. So there are things that are being done to try and help resolve some of these queues issues, but clearly there's a capacity and demand issue that we're having to face into here.
Lee?
Yeah, just to clarify, you've put down here obviously the 6 surgeries or 6 pharmacies that are closing. What was the reason for these closures? Can we drill down the simple reason to why these are actually closing? And the second point is to pick up on what the chairs actually said. We know for a fact when you close Chard Road down, the extra footfall into Stirling Road broke the back of it. We know when you close Collins Park down the CCG, it broke the back of Manor surgery. So how many patients to each of these 6 surgeries are going to be diverted as a total number? So we know the total number of people affected, and we also know the impact then directly in relation to the other surgeries that are going to have to pick this up. Are they going to be able to cope with the extra numbers coming through their door?
Yeah. So we do have that. So when you say other surgeries, you mean the community pharmacies? Yeah. No, that's fine. So yes, we do have. Also, we can share that. I haven't got it with me, but we've got that, and that's the assessment we've had to go through. I can't tell you off the top of my head, Lee. I mean, I don't know whether David or Melissa can. I'll get them to think about it in the background. But we can share that with you. So I'm very happy to give that to you. It's not a problem. And as we said, it will be very variable across those pharmacies as well in terms of impact. So for some, it will be a lot less scripts than we're talking others. So from my vague memory, we're talking from a range of kind of 1,000 to kind of much more in the kind of double figures is my recollection of the numbers, but we'll give you the exact numbers. But in terms of the impact, that's what we've been doing in terms of working with those pharmacies. So we've been able to say to them, this is what we think the impact is going to be on you in terms of number of scripts. Is that something you think you can cope with? So we've got that, so we can do that. The first part of your question, Lee, sorry, you have to remind me.
No, obviously we know that these pharmacies are closing. What is the reason given for the closures, please, so that we're aware? And is there anything that could have been put in place to have prevented that in the beginning? Was there anything structurally that could have been put in place to have prevented the closures?
Yeah, no, absolutely. And that's what we're trying to explore at the moment. So by setting up that group to forward look, we're trying to understand what are the reasons for some of this and can we predict some of this? In terms of the boots close, I might come to Melissa in a moment because she's just been a little bit more closer to the conversations. But my understanding is that is a business decision from them to consolidate. But I don't know, Melissa, whether you can give any more specifics on that.
Yeah, that's the information that we've been provided, that it is a business decision and mainly financial.
Oh, put my glasses on, it would help, wouldn't it? John?
Thank you, Chair. My experience is like that of our chair, Pauline, that most pharmacies are pretty frantic. And they don't, most of them, or a lot of them, have very big premises. I mean, they may have one small room where they can see patients and discuss things. And I always approved of the extended role of the pharmacist, but I don't see how that is compatible in many pharmacies where they're struggling for staff, and they're lucky to have a pharmacist, and it's often a locum pharmacist. They haven't got many backup staff. All the staff now are sat in general practice, and a lot of general practice has spare rooms because, you know, patients aren't attending as much as they did, so there's a lot of capacity there. So the question really is, are all these pharmacists that have left community pharmacies, and I wonder whether this is why Boots are reducing the number, they can't get pharmacists unless they pay extortionate locum rates. Are we getting value for money from the pharmacists that are now in the GP practices? Yes, rationalising medication, saving money, make it safer for patients, but are they actually giving the advice? You know, because if we're encouraging community pharmacists to do that, but they haven't got the capacity, the time or the space, and the ones who've gone to general practice aren't, what is happening? That's my question. So I think the pharmacists in the general practice, I think the general practice people would say they're giving them huge support in terms of their delivery, and they are actually, in terms of ARS roles, I know that they're deemed as really important ARS roles in supporting the practice function. But from a community pharmacy perspective, I think it's important to state that the business model, the way we operate, is significantly changing, and that's happening in several ways. It's happening because quite a number of pharmacies now get a lot of their prescriptions actually dispensed and collated off-site, and it comes back to the pharmacy for the intervention and counselling with the patient. So that's probably why you're seeing less staff in the pharmacy premises itself, because it's being scaled in order to drive efficiency. Not in every location, but in a number of them. There's also a recognition of the role of the technician now in the pharmacies is growing. It's becoming really, really significant role. Legislation is changing to enable them to do vaccinations and do all kinds of things going forward. And they are becoming the bedrock of actually the supply process as well, freeing up the pharmacist to do the supply, so the service interventions that we've talked about. And it's worth mentioning that from 25-26, the pharmacists come out of university will be going into a foundation programme where they'll train to be IPs. So from 26-27 onwards, pharmacists going forward will be IPs. And that's part of, independent prescribers, and that's part of the Pathfinder project to allow that to grow. And the government's intent is for pharmacy to act as the first point of contact in a lot of these things. So I agree with John, that's a really fundamental thing. And part of the process of growing that is the new services that have just been announced. So there's 8 PGD services, you know, Impetigo, UTI, all kinds of things that are coming on stream from January to allow us to grow that service function even further. So it's really important we do have time in terms of the pharmacist day to actually offer those interventions for the public. But we can only do that, you're right, in changing the way that the actual pharmacy, community pharmacy service model works, or the actual workforce model works. And that's the thing that's in train in the moment in terms of skilling up the pharmacists to do different things, but also skilling up the other team in order to take on a lot of the activity through the supply function. So is a change happening, John, and it's really, really positive for the future. But obviously the supply-demand aspect of it impacts on your ability to deliver services. That's why we need to make sure that the actual staffing levels are right to make sure we can offer as broad a level of service interventions as we possibly can.
Steve?
It's okay. Okay, thanks, Chair. Yeah, I've had a few sort of sad emails about this from local residents, so it's really hit home this subject. So I'm glad we're looking at it today as a council. And the question they ask is, I know we've sort of gone into it, was why have they closed? And I'm unable to give them a decent answer, and I'm glad we're getting into it now. Melissa said it's a business decision. Hopefully we can just get a bit more information back to them in simple terms. There's a lot of words here, but if we just give it to them straight, they can take it, yeah? So, for instance, Claremont, just a bit of feedback, you know, they're upset because there's excellent customer service there. That it's really hit them, and it's going to be sad when that closes. So, are we able to get a bit more of an expansive answer rather than it's a business decision? A bit more meat on the bones, but keeping it simple at the same time.
Yeah, thank you, Steve. Yeah, it does sort of hit home when you hear that feedback, because actually community pharmacy is somewhere where people go to for advice. It's often very local to them. So I think what Boots have fed back to us is some of those staff, which will be the staff that kind of people know and trust and rely on, will potentially work in some of their other sites as well. But, you know, still appreciating that won't feel, or at least at the beginning, won't feel the same to them. Hopefully over time it will. I'm quite happy Melissa and I can go back to the team and see if we can get some lines for you that we can share that are just a bit more meaningful and maybe a bit more pointing towards what the future and we hope will look like as well.
Thank you. And the next question, I suppose, that I'm just thinking about the emails that I've received on this. The next question is, how can we keep them open? How can we stop this? I'm just trying to get it right down to how the end user is. So I know it's not an easy one, but how can we keep them open again? Is there any way to do that?
Yes, so I'll start. So I'll start. I might ask David to comment a little bit on the wider, because obviously I've got a view in terms of the NHS aspect of this, but community pharmacy and the wider business model is much more than just the NHS prescriptions, isn't it? So I mentioned earlier on, we set up a small group to try and identify what some of the factors are. I mean, we know what some of the factors are, the driving factors in terms of workforce and finance and the way that the contract is being recompensed at the moment. So we know what some of the bigger drivers are, but we want to try and get underneath what some of the particular issues are here and whether there are things we can do to try and predict some of this and then work proactively with these organisations in the future. Sometimes it's quite difficult where they're large corporates to necessarily get into that conversation before the decision's been made. So that ties our hands a little bit, particularly where we've got, you know, and we want to treat all of our providers the same, but particularly where we've got the opportunity to have those conversations, we want to get into those conversations early to see if there are things that we can do to support. It works, community pharmacy works in a very different way than some of the other services that we commission, where we commission the whole service, and that includes the buildings and the workforce, and it's a very different model. So we need to start, as an ICB, we don't yet understand that, so we need to start getting into some of that. One of the things, or two of the things we do want to do is obviously really focus on the workforce element, as David's described, but also really support them in terms of those clinical services they want to provide as well, and make sure that we can really get footfall through the door and we can get the appropriate referrals from primary care networks, as an example, to make sure that that's helps in terms of the sustainability and business model moving forward. I don't know, David, whether you want to add anything else.
I mean, I can't give you specifics on any location, and I can't really tell you in Boots in general. I can just tell you about the general nature of finances in community pharmacy. So if you look back 10, 15 years, you would have made a reasonable return on delivering a supply function in terms of doing a prescription. The last 5 years of contracts been flat cash. So there's been no increases in remuneration to community pharmacy until the services that have just been announced starting in January. Now, through that period, not only have pharmacies had to deal with no increase in money, they've also had to deliver a whole number of services within that envelope to get that money back to flat cash. And as part of that process, it's meant your return on delivering the supply function, i.e. prescription, has gone down and down and down, to the point now where actually doing the prescription element of service is not really generating huge profits for the business, if any, in some cases. So services now is far more significant in terms of the remuneration package. Now, that has meant that when you look at the models you went into 10, 15 years ago, like going into GP practice or whatever, a reasonably high rental, those economic mechanisms and structures have now changed. So the whole economics of looking at different locations is now different to what it was 15 years ago. And that's now beginning to play out. And also within that, when you're on low margins, things like locum costs and things like that, which are higher down in the southwest, will play a part. So I can't give you a specific answer about a specific location or about boots, but those are the type of things that are impacting on community pharmacy viability, if that makes sense.
Well,
obviously, there's concern that this is just a business decision by Boots or whoever else. But obviously, there's a bit of concern if people, the slides mention people using the online pharmacy service. So whereas, you know, Pauline got a prescription filled at a local pharmacy, that money goes to there. As online, it could be anywhere. You know, I don't know whether the companies like Boots want people to just use their online service and they've got rid of their shops and what have you, but the shops doing, they provide an anchor for lots of parades of shops and community areas. They provide employment, they provide training opportunities, and if I assume like technician roles or assistant roles. Is that what you do whilst you're doing your finishing some of your professional training? So, you know, what can be done to ensure that the money from the prescriptions actually stays locally, doesn't just disappear off to, I don't know, there's all sorts of wheezes companies could do to, you know, that we just lose that ability. We're the local organisations are paying the money for the prescriptions, but the business for that prescription isn't going into our local communities. It's just disappearing to another part of the country and not providing the opportunities if you're going to have a pharmacy college to train, to give people training or the opportunity to train. So,
yeah, thank you for your question. Well, it's a really good question, and not all of this is within our gift, is it? So, you know, I think online is here; it's here to stay. And there'll be some patients that will be a good option for, and they'll want to access it in that way, and they'll choose to access it in that way. It's a little bit like a e-consult for general practice. In some ways it's different, but in some ways, but patient choice will avail. And all we can do is work with our local providers to understand what we can do to support them whilst that other option is out there. And as I say, I wouldn't want to, you know, let's not, you know, there will be patients who will choose and will want to use that. So I don't want to, you know, say that's a bad thing over there, because it isn't. It will be good for those patients, but at the same time, that does pose us significant challenges and poses some significant challenges for our community pharmacists. And I think the best thing that we can do is to work with them in our local forum to understand what are their challenges and what can we do to help support them. And some of those things that we've talked about around those additional clinical services that they can offer, actually, if they offer those services and people can see the benefit of that, then that will, I hope, will keep them wanting to use that local pharmacy for their prescriptions as well and for other things as well. And as you say, that keeps then the whole business model going and keeps people employed locally. But it's got to be around that wider offer. It can't just be a conversation about the prescriptions, because what we know is, what you've heard from David, is at best you might break even with that. You need those additional services, and then beyond that, you obviously need other things that they can provide as a wider pharmacy to enable them to be sustainable. So I think we've got to work with them. We've got to hear what they're telling us, and we're going to have to come up with some innovative solutions, because there isn't a blueprint, if you like, nationally for how we make this work. There has been some helpful stuff come out recently, actually, nationally, in terms of sort of direction of travel, which we will use within our local strategy. But it is our strategy, I think, that has got to be the focus for us. Yeah.
I just wanted to add a bit to that as well, because why is it important you've got a local pharmacy network, really? Obviously, it helps in terms of patients that find it difficult to access online services, but also fundamentally, it's really, really important going forward under the national strategy, because those services that we're going to provide will be really, really vital in terms of reducing demand into the rest of the health system. And not only that, those services are actually funded centrally. So it's one of the few areas that actually we can bring extra money into the local system and actually build our capacity to actually deliver demand on the back of a nationally funded approach that doesn't come through the local system. So from a financial perspective as well, to build resilience, it's really, really important that we have a vibrant, effective community pharmacy network to actually offer that first point of contact and actually deliver a huge chunk of those interventions that are required at low level for the system. So it is actually really, really important in terms of the financial sustainability of the wider system, particularly primary care as well. So, you know, it's not just about the supply, it's very much about, you know, helping with the supply-demand situation in primary care. So it's really, really important that we keep that network going and we offer good access to that network across the city. And that's the bit I think we need to think about here, about how we proactively do that. And I think we all have a role in that, the council, the ICB, us at Community Pharmacy Devon, we all have a role in becoming more proactive in deciding what we want out of the community pharmacy and making sure we have a vibrant system going forward. And the council obviously involved through the PNA, through the Health and Wellbeing Board, and it's really, really important we have more creative discussions going forward to enable us to make sure that we make that offer better in terms of, you know, proactively delivering what the patients need.
I've got Natalie and that's it.
Thank you, Chair. Regarding the independent prescribing Pathfinder programme, briefly mentioned that and said that there were going to be 8 community pharmacies in Devon. Are there any in Plymouth? Is there the opportunity with this Pathfinder? I don't know how long the programme's going on for. Is there an opportunity for that more information to come back to Scrutiny regarding what that means and how the programme is going, that type of thing, because there's sort of very little detail there at the moment. That's the first part. And the second part is there was mention about graduates and there being a challenge in terms of placing graduates. Is that because of the reduction in pharmacies, or is there another reason why there might be a challenge with placing our students?
I'll answer the first bit, and David, I might ask you to answer the second bit. So yes, there are within Plymouth as well. Out of those 8, I'm very happy to come back here with the findings from that. It's a really good opportunity. We're really pleased that we've got 8 within Devon. So yeah, very happy. We'll talk about when we need to schedule it in. But yeah, absolutely, that would be really good opportunity. David.
And just a bit more on that, actually, one of the ones in Plymouth is going to do something really novel as well. There's going to be anyone in the country doing it, so you might be quite interested. So in terms of workforce, there are a number of dynamics going on here. The difficulty with placements is primarily around the fact that in 25-26, we're going to need what we call a DPP, a designated practitioner, to actually train people to become prescribers as part of that role. Now, we haven't got vast numbers of those people, and actually a number of those people that we might want to use sit in general practice that have already got a very big training burden. So I'm actually on Friday going to start talking to someone about how we think about the training models, etc., that we've got and how we can increase our capacity. There is a mechanism we've got, actually one of the few in the country. We've got a teach and treat hub actually at Derriford, which is aimed at providing DPP support for the people who are currently training in independent prescribing, which it has increased our capacity amount, but it's time limited, it's only for a couple of years. So we need to think about how we might expand that as well, which we haven't got an answer to at this point in terms of funding. But that's the primary issue around graduate, and it's fair to say that the numbers of graduates coming out and the number of placements generally, because the pharmacy course is changing, the number of placements at undergraduate level is tripling within the system. And also the number of graduates themselves. At Bath, they've gone up from about 70 to 140 in terms of year groups, in terms of what's going to be coming out. And on top of that, we're going to have the Plymouth graduates. So it's pure numbers, it's change in the nature of the training that have actually driven increased levels of demand and increased complexities. So all those things factor in means that we kind of need to think a bit differently about how we're going to lay those training places down, really. They're challenges we recognise and we're facing into, and we're trying to develop solutions for at the moment. I'm sure we'll come up with some solutions to allow that to happen, but at this point in time, they're not fully formed.
Just a quick one from me. It's either a yes or a no answer. The health and wellbeing hubs that are going across the city, are they being considered, or are pharmacies going into these health and wellbeing hubs?
I can't answer that for you, but I'm very happy to take that away as a question to understand what the opportunities are. Yeah.
I mean, if we've got GPs going in there, I can't see why we couldn't have a pharmacy go in there as well.
It's not quite as simple as that because of the P&A and control of entry requirements. So it may be possible, but it would require a consideration around the P&A whether that's appropriate or not.
But it is consideration.
In some circumstances, possibly, but you can't just say that people can go into those hubs, but it has to be. It'll have to go through the NHS England.
So that was to know. So what we're recommending is that the HWB consider a supplementary statement to the P&A at the next meeting in January. Yeah, you agree? Yeah, sure. Okay. Can I thank you, Joe, and thank you, Dave, and people that are online for being here today. I know it's not easy to face councillors because sometimes we just don't probably understand what you understand. But I'd like to wish you all a Merry Christmas and hopefully see you all in the new year. So thank you.
Thank you very much.
Thank you. We're going to go on to item 10, which is adult social care, CQC assurance and self-assessment. And I've got Gary online, got Rob, and I don't know about Jodie and Jeff. Jeff? No, and Jodie? Jodie's online. There you go. So who's going to start?
Thank you, Chair. There is a presentation in your packs, but given the time restrictions, I think it's probably fair for all of us that we don't actually go through that and point you in the direction of that to please review and come back to us with any questions that you might have. It tells a story about the Care Quality Commission assessment framework, which is essentially a new framework which sets out that the CQC can now inspect local authorities on how they deliver their adult social care and how they deliver against the requirements of the Care Act, which was set out in 2014. The new assurance programme went live in April 2023. The CQC have done 5 pilot inspections between then and now, and in the new year we'll undertake the first 20 assessments of other local authorities that are yet to be determined. Plymouth City Council may well be within those first 20, we may not. It's very much an unknown at the moment. We've been doing an awful lot of work around preparing ourselves for when this may happen. It will happen at some point over the next 2 years, that's a definite. Over those 2 years, CQC will be inspecting every local authority and setting a baseline, at which point they'll move forward into a routine inspection programme, a bit like Ofsted do for children's services. It's the first time in about 12, 13 years, I think, that adult social care services will have been inspected in this way. An awful lot of work's been done around self-assessments, evidence capture and review, and we're working very closely with our colleagues at Live Well South West, obviously as they are commissioned to deliver our statutory adult social care functions. I'm going to hand over to Jeff now, who's going to provide some assurance of how we're working together and how Live Well are preparing as well.
Thank you, Chair and committee members. So my name is Jeff Baines. I'm Deputy Chief Executive at Live Well South West, and specifically the value that working together, as we do very closely anyway, brings is that I'm the CQC registered manager for Live Well, and so of course we're very used to regulating activity. You heard earlier today about Mayflower and the work that we did at Mayflower and so on. So we've got lots of experience with the Care Quality Commission, and as Rob said, this is the first time really under the Care Quality Commission in any case that local authorities anywhere have been inspected. So it's new. It's a new process for local authorities and for the CQC. So, but working together on that, being prepared for it is really important. Now, I think one of the key messages I wanted to share was often, and as we've seen with Ofsted particularly, but often people get very worried about CQC inspections and what that means. But actually, I can absolutely guarantee it is a fantastic opportunity to benchmark yourself, particularly when we haven't had through local authorities that chance to do that before. And to really celebrate all the great achievements that have been made, and partnership working in this city is really, really good. And I think, as you've seen, and the fact that we're talking together as a local authority and a health social care provider demonstrates that. So I think there's great things to celebrate. What we're also aware of is the team, the local authority team, so Gary and the team, and Jodie and Rob and others, and myself and our team have done absolutely all that they could possibly do to make sure we've got the very latest intelligence, if you like, on best practice throughout the country, from the 5 pilot sites, the feedback from CQC on what they're learning. So we're building that into our preparation process collectively. So we're putting ourselves in as best position as we possibly could be. In fact, Gary and I were talking this morning about having to redo our self-assessment in the light of the feedback we're picking up from these pilot sites. So it's really good. We're getting the very best latest position from elsewhere. Last week, I had the opportunity, along with Councillor Aspinall and other members of the council, to listen to Helen Watley as the Minister for Care Services talking about the approach around this, the head of CQC inspection talking about the approach, and the 2 councils, Leicestershire and North Leicestershire, who have both been in the pilot sites. So we're listening to their members, their cabinet leaders and their officers about it all. So we've got the very latest information to bring back to Plymouth to prepare. And so we're in that preparation phase right at the moment. So, and with all preparation phases, the fantastic thing it brings us is naturally it lends itself to improvement plans. So you benchmark yourself, you focus in things in a way that, to be fair, without a CQC regulation, you wouldn't probably look at in the same way. So I think it's a really positive thing for us to do, and we're right in the middle of that phase at the moment. And I think we're expecting by end of January we'll be in a strong position with our self-assessment, and we've just got to wait to hear about notification at what point in the next 2 years we're going to be part of that inspection process. But we should really welcome it, not be fearful of it, and then when we get the results of it, we work really hard to continue to improve. And that's been the experience we've had at Live Well, and I'm sure it's going to be the same for us as a partner with you alongside a local authority. So that was, and I know that collectively we wanted to share this set of slides with you and just to give you that information, and certainly there'll be more information on the results and everything to come back to you at a later time. So hopefully you'll find that as a helpful prelude to the inspection when it comes.
Gary, do you wanna say anything?
I'm just a little on to build on what people have said, and I think Jeff's absolutely right. the process itself is designed to assure, and it will be and in that way it will be really, really helpful for us. I don't think I know anyone who is always eagerly awaiting the arrival of CQC because they judge, but it is a very assuring process. We'll look for those opportunities to come back, because I think the one thing we know for sure is that what we will have very soon is what we'll call our improvement plan. I think everyone who has a regulatory inspection has an improvement plan. Doesn't matter whether you're shiningly good or in the requires improvement session, you need an improvement plan. And I think there's opportunity there for scrutiny moving forward as well that can really add weight to that whole process. So I'm hoping to be backup points to update people around what we're doing and share some further information. But other than that, I can only agree with the comments from Rob and Jeff.
Thanks, Gary. Jodie, do you want to say anything?
No, I would just follow up the same as them, just that we're working really hard to just gather all the intelligence so that we can build a really good base to start with. Once we have more information, we'll be able to share it.
Lovely. Thank you, Jodie. Alison?
Yeah, I suspect the answer is we don't know, but you know, and I fully accept scrutiny can be and should be a very positive process. But you've already been doing preliminary work on this, obviously, and you're reasonably confident that what you're finding is whether there are any issues, they're manageable. But have you lifted the rug, and are there any sort of standout areas that you really do have concerns about, that you think we could do better there before we get inspected?
So thank you for your question. Yes, is the answer. As part of the work and as part of the self-assessment work we've done, one of the slides that would have been in the pack actually just draws out some strengths that we've identified, but also areas for improvement. I'll just read those out to you. We do have concerns around undertaking of reviews of care packages, which is something that's been ongoing for some while, and we already are working to improve that with colleagues in LiveWell and with commissioning teams. Evidence of checking social work practice through file audits. We know that CQC will want to look at case audits. 50, in fact, we will have to identify 50 cases that they will want to audit. So we need to make sure that we are completely on top of that. This is a big one, and we are working to try and fill some of the gaps around user feedback. User feedback, engagement and access to information around services. We have a lot of information out there. We have Plymouth Online Directory, which has an awful lot of signposting and information, but we know it's a key area that CQC will look at, and we know that it's an area that we probably need to improve in, and that will certainly form a big part of any improvement plan going forward. And we also, whilst we have a very good carers service within Plymouth, we do know that our performance against national indicators in terms of carer satisfaction isn't as high as that we would like it. We perform really well in terms of user satisfaction, not so well around carers, but we're trying to bring to the surface all the good work that Improving Lives Plymouth are doing, for example, and paint a much more positive picture around carers that we know the national indicator is perhaps showing otherwise. So there are some areas, that's just a few. That isn't a definitive list. As we go forward, that list will change. There will be other things that we identify, I'm sure. That's just some of the things that we've identified to date.
Angela?
Thank you. I just wondered if there's any link at all between this CQC process and their process with other providers in care homes, because my impression is quite a lot of care homes are anticipating a visit quite soon.
Yes, thank you for the question. So, not really, but in fact, everything that is done by CQC gathers intelligence of a community. So
The inspections of the care homes and the CQC regulations for care homes are separate to, and there's slightly different methodology than this new approach being used for local authorities. But what CQC as a central agency will know is what the ratings for all the care homes are in Plymouth, what all the GP surgeries are in Plymouth, what Livewell is in Plymouth, what Derriford is in Plymouth. It's all a part of their suite of intelligence. So when they come to speak to the local authority, they'll know all of that information anyway. So it's not connected, but you can't do one without the other. But there are separate regulatory regimes. But it all adds to the pot of the community's position.
Lee?
Yeah, it's just a quick one with regard to obviously user data. Customer satisfaction plays a big part in the CQC reports. What is happening to collate that data, and how is it being represented at this moment in time?
So we have statutory surveys that we have to do around adult social care. So every year we survey all our long-term users, not all of them, a sample of them, which normally totals around 1,500 questionnaires get sent out. We perform well in most of the indicators around that: satisfaction, feelings of safety, feelings of social isolation are relatively low compared to other areas. But we don't perform very well in terms of how easy people find it to access information around services, which is why that was raised earlier as an issue. We survey carers every 2 years. Again, that's mandatory. Every local authority has to do that. Our outcomes from that survey are not as good as the user survey. Satisfaction is lower and below benchmarks. And similarly around access to information as well, which is why carers is a big area that we know we need to focus on. Having said that, Improving Lives Plymouth, who are commissioned to do the carer service, do their own surveys, which actually gives a little bit of a much more positive picture. So there might be an element of getting a survey from the local authority reacting to that differently than getting it from your actual provider. I don't know, but they do provide two different stories. We within the local authority we do internal forms. So there are some of our services within our retained client function have feedback forms that its users are are given the opportunity to fill in and feedback how their service has been, and we collate those locally and try and make sense of those. Not many get filled in, I have to say, and that's part of the things we'd like to strengthen that. I'll hand over to Jeff because I know Livewell do a lot more.
Only really to say that as part of the preparation process, we're looking at all sources of feedback. So that's a statutory plan around getting the annual survey. But in addition, and I know Tony Gravitz on as well, so there's Health Watch feedback that gets picked up. There's been surveys that we've done through the Adult Safeguarding Board around people's experience of that. And so there's other sources of information. And so the benefit of us working together is to try and gather everything that we have. And I think it links actually to Councillor Rainsford's question also around what do we know areas for improvement. And I think the key for the CQC inspection is that we all know our own position on things, and where there is areas for improvement, we've got a plan to do something about it. So it would be a real failing actually if we didn't know that we had bad feedback. And so that's the key thing. So as long as we know our current position, and this, as I said earlier, naturally allows you to have really good improvement plans in different areas. So we think we could do more. And I think the only last thing I'd say is what we're valuing from the intelligence gathering from the pilot sites elsewhere is there are areas that were focused on which included carers, included transitions, included co-production with people who use services. And those are things that elsewhere have been looked at strongly. So we can anticipate they're going to be looking at those for us as well. And so let's do more about it. We're keen to focus on that.
Hang on, Lee. Gary just wanted to come in before.
Thanks for that. I think I just wanted to emphasise actually, and just cover some of the points that firstly, self-assessment, understanding where you are and your strengths and your weaknesses is really, really critical for us. And those things will change over time. So Rob shared with you some of the things that we think now, but the system's working on them. We don't know yet when CQC will come. If they come in 6 to 8 weeks, we're likely to show self-awareness of the areas to improve, similar to the ones Rob's talked about. If it's 6 or 8 months, we may have made progress on some of those and learned some other things about it, and it will move and evolve. And I think that's really important to acknowledge. With regards to the voice of people, I think I just want to agree with some of the words, Lee, that you said. It's a really, really important line for us, which is why we've highlighted it as something we want to improve on. But please don't hear that that doesn't mean we're not doing things. And you heard quite a lot of the examples of where we are doing some engagement. But we know through the learned experience of some of the CQC assessments that have happened to date, and from the importance, we are here for those people, and we're supporting some of the people in our city. We need to make sure that we're taking every opportunity to listen to their views and to understand their needs, so we can respond in absolutely the right ways for them. So it's likely to be a continued theme through the work we do.
No, Chair, I think Gary's basically clarified the point that we're actually learning from our weaknesses and we're engaging with those portions that aren't quite with us at the moment. So in future, it gives a better a picture of where we are, and gives us, I suppose, a preemptive strike on the CQC, knowing that area is okay and it's an area not to worry about. Thank you.
Thanks, Lee. Just a quick one from me. If for whatever reason CQC come in and you said that you've identified things already that you need to look at, like waiting lists and that sort of stuff. So if CQC came in and they said, actually, that's not good enough, you need to bring that down within the next 6 months or whatever, that list or whatever it is that going to have a budget constraint on us?
So I'll tell you what I know in terms of the legislative approach, if that's the right word, and then I'll hand on to Jeff, who's got a lot of experience with CQC. All I can say at the minute is from what we know is if, and we obviously hope this doesn't happen, we were rated to be inadequate, there is legislation that allows for an intervention, and that intervention potentially will have a financial cost on the local authority. Potentially. That's all I really know in terms of the financial impact of this. Jeff may talk about CQC's general approach to these things.
Well, I can only feedback from the head of the CQC Adult Social Care Inspection, who we heard speak 2 weeks ago, who was asked this very question from members of the audience from other councils. And the assurance he gave to the conference was that the Care Quality Commission will be taking into account the context within which they're inspecting. So, the financial pressures on local authorities are immense, and you'll appreciate in the conference there were people there from Nottingham and others, talking about the difficulties there are. So it was acknowledged by CQC that they're not going to be unrealistic, but they will be taking into account the sort of financial implications of where they are as part of their assessment. So, but I think to improve things, we all know you need to invest in them, don't you? So it's always going to be an issue, but they did acknowledge that.
Gary, did you want to come in?
I just wanted to add, if I might. So if, and we hope and we don't believe that that's the position we would be in, but if those were the judgments, I guess there are two things. We know through, if you like, Ofsted inspections and inspections in other places that poor inspections tend to cost money. in terms of improvement. But you're faced with two choices, so it's not as straightforward as going therefore it will. You have to have a look, because there are two things you can do. You either need to reprioritize some of the things you're doing to get to enable you to focus in the areas of most need, or you need to bring more money and resources in to help you improve, or you do a bit of both. And I think that would then depend on the area of judgment and the kind of actions required. So it's one of those lovely vague answers, but I think until you know the detail, you can't say. But we do generally know that for services to get to a good standard from a really low base, there's often a price tag involved.
I've got Alison in there. That's the last. That's the last one I'm going to.
Just a very quick one. In preparing for this, have you had to spend money to do that? And if you have, is that something that can be reclaimed under the new burden scheme, which I think probably is still in existence? Government placed a new burden on you. Is it reclaimable?
I think that's a question for me. So when preparing for inspection costs money because it takes staff and it takes time. That's not new money. What we do is we use the staff we have and we prioritise the work that we've got. I haven't heard of a claimable scheme for any of that money. It is done through the social care settlement.
So basically you haven't had to call in any consultants or anything, you're just doing it all in-house, end of.
Some have that use consultants and therefore have paid additional money. Plymouth hasn't, but what we do is work a lot with our region, and we do a lot of regional work together to make sure that we are learning and working together, if that makes sense. We work with the 15 other authorities in our southwest region, and we do a lot of work with them in terms of joint development. I think we've had staff this very week up in Bristol helping support them with a peer review from which we learn, and we bring all of that back as well into our system. So that's the kind of some of the mechanisms that we've used.
Can I just thank you all for coming today? Thank you, Gary. Thank you, Jodie. Thank you, Rob. Thank you. It's lovely having you here, and hopefully you'll have a lovely Christmas, and we'll see you in the new year sometime. So thank you very much. That is actually the end of the.
Thank you.
That is the end of the meeting, because we'd already done tracking and work programs. So that is the end of this meeting today. Can I thank all of you for being here, and it's been lovely being with you since May. So all go in, have a nice rest, have a lovely Christmas, and be back in for the new year. So thank you very much.